needs, of course, to be done. We always have that, and we have some more coming up. So, but basically, pain relief during second stage of labor with or without pudendal epidural analgesia, and probably especially in instrumental vaginal birth. And then, of course, it's very efficient for suturing after birth.
Thank you, Asa. There is another question for Dr. Daniela Menachini.
Yeah.
In the study regarding malpresentation in women with an epidural, was there an assessment of fetal presentation prior to insertion of the epidural?
Yeah, thank you for the interesting questions. It is an important point that unfortunately we did not evaluate. So for sure, for the next study, we will evaluate first the malposition, the fetal head position diagnosis, then perform the epidural, and then see if the position changes or not, in order to be able to express who comes first. I mean, I saw the other questions. Of course, if we want to see if there is a causal association, we need to see the situation before and then after. This was just to have a panoramic and observation on the relations. Yeah.
There are several questions directed to you also. According fetal malposition and epidural, what is first? Of an epidural, yes.
So the epidural is not the reason, but the consequence. We don't know yet. I mean, a fetus that is malpositioned have longer and more painful labor. So women are more prone to request epidural. So really, who comes first? We need to design a better study for sure. Yeah.
Mm-hmm. There is another question of there are decelerations in the fetal heart rates 20 minutes after the epidural. What is the mechanism and what do you do? I mean that with the modern regimes, I think this question is directed to me, but please feel free, any of you, to try to answer the same or different to my opinion. I think that when they speak about decelerations in fetal heart rates, they're speaking about combinal spinal epidurals. It is a transient alteration of fetal heart rate, and it's due to the decrease in catecholamine release and the effect of opioids. The effect of opioids provoke fetal bradycardia, but in the most recent and wide studies, it has not been demonstrated an increase in the cesarean section rate. Let's remember that we don't have to perform C-sections to the cardiotocographic registry. We have to perform C-sections to the patients. We don't have to operate the registry.
I think that also, I can add also that it's also sometimes related to the which kind of opioids do you use, because I mean, the women respond differently. For instance, if you use sufentanil, for instance, then you can have some bradycardias, but I mean, are just the babies that is sleeping. It's very, very fine cardiotocography trace. It's just bradycardia, but not stressing, because it's not related to the uterus. So it's I would not say. I mean, it's
it is not related to fetal stress.
It's not linked. I mean, you can see some bradycardias of induced by opioids, but really the trace is so it's not something that is scaring. I mean, anyhow, we should always be alert, because it's delivery, so it's a labor. So we can also have some alteration, but not linked to the epidural.
Any comments concerning assisted vaginal birth? I mean, we have talked about the increase, the possible increase of assisted vaginal birth, if you mean forceps or ventosa or something like that. If we use modern epidural analgesia regimes based mainly in avoiding continuous infusion and giving the possibility of PCEA and even programmed intermittent epidural boluses, the probability of increase of instrumental delivery is not significant. Is not significantly. But if you give manual boluses, continuous infusion, and high concentrations and high volumes, you will have for sure malpositions and an increase in the instrumental delivery rates. Do you agree? Do you all agree? Or the next question is, I'd like to know your opinion about analgesic bomb in epidural analgesia. I think we have answered already that question. And do you have a position about when use analgesia, for example, before 4 centimeters or after 4-5 centimeters? Our position is whenever the woman complains about pain. Some women complain at the beginning, especially if it is their first labor, and it is not related with an increased percentage of C-section or instrumental delivery. And even if they are in complete dilation, we put a combined spinal epidural if the woman wants epidural, neuraxial analgesia in this case.
Yeah,
So don't forget that the more painful labors are more prone to have a C-section with or without epidural analgesia.
Yeah.
Because
malposition. I would also to stress the concept that we have not to consider analgesia at certain dilation, but it's just if the woman has expressed the will to have an epidural analgesia as soon as possible. I mean, and we can start because we can modulate our analgesia according to the stage and to the quality and quantity of pain. So I think that we should start as soon as possible and deliver, offer to the woman what they need in that moment, and we are able to do that. So it's not on off.
Yes.
So and that should be clear. It should be clear.
Yes, we have to try to tailor the analgesia.
Yeah. Yeah.
It is not coffee for everyone.
Yeah, and we have opioids, and we have the local drugs. So we can really tailor our way of offering
yes,
pain control.
Another question for Daniela. The study of fetal malposition could be because the patient with a fetal malposition have more pain and request for more frequently for analgesia?
Yeah, as we already said, the labors of those women are more painful, so there is a higher percentage of women requesting it. So, yeah.
There is another question. There are several, it's much more a comment than a question. Several publications have concluded that combined spinal epidural is linked to increase the occurrence of non-reassuring fetal heart rate tracing compared to epidural. Do you explain this when asking this consent? How do you recommend educating the patients for possible fetal complications linked to difference in type of anesthesia? Well, I must have read different publications because the last publications, the science is changing all the time. And the last year's publications say that these fetal heart rate tracings of combined spinal epidural do not lead to a more an increase in the incidence of C-section or worse fetal outcomes, as we have mentioned before. Science is changing all the time, and modern regimes of combined spinal epidural and modern regimes of epidural analgesia are neither of them related to an increase in C-sections. So there's nothing to explain regarding to this to the ladies.
No, I think also it's not necessary to go so in deep in the information. Otherwise, I mean, we should tell the woman thousands of things that it's impossible to, and it's also not necessary, and it's confounding a lot the woman. And so I would stick to the main aspects of the complications and of these techniques.
Mhm. There's another question here, but I think we have answered it yet. When do you offer analgesia in terms of dilation? Whenever
We have
the
done, already
lady
done,
wants.
already done.
Yeah. Yes. I think we don't have any more question. Can you see? Please help me.
I'm just
Can you
looking, I was
see, Irene?
checking.
I think we have answered all the questions that
Seems to
have been
me.
asked.
Yeah, yeah.
If you have any additional question, please feel free to ask. We still have 8 minutes ahead of us before the end of the session. Let me remind you that after the end of this session, you will have a break. And during this break, you will be able to visit the commercial exhibition, and you will have also the possibility to visit the poster sessions. And please ask your questions. And if you don't have any additional question, I think it's maybe the moment to close the session.
Yeah. Good. Emilia, you make a wrap up and close the session, okay?
I will close the session. Okay.
Yeah, please.
So thank you very much, Dr. Eduardo De Robertis, Mr. President, Dr. Daniela Menichini, Dr. Assa Baldum, and also thank you to Dr. Giancarlo Di Renzo, who has been watching all of us and trying to control that everything is going fine. Thank you very much, and I thank you for participating. And let me remind you, the next session will start at 1 o'clock, and it will be spontaneous preterm labor, and will be chaired by Dr. Luis Cabero and Roberto Romero from USA, Luis Cabero from Spain. Thank you very much, and I hope to see you soon.
Thank you very much.
Very
Bye.
nice.
Bye.
Thank you so much. It was a very nice session, a lot of questions. Enjoy. Okay. Okay, now we can rest a little.
to chair this session with Professor Luis Cabero from Barcelona, Spain. We have an exciting session in spontaneous premature labor and delivery, which is sponsored by the Price School from Florence, Italy. We have a great set of speakers: Eduardo Gratacos from Spain, Teresa Cobo, Eduardo Fonseca from Brazil, Jerry Wiese from the Netherlands, and I will close this session. Luis, can you join me to welcome the participants?
Okay. My first words is to say thanks to the directors of the meeting for inviting me to chair this session with one very important person like you, Roberto. I think that this session can be one of the most important of the meeting because, as you know, prematurity, it's a big problem around the world. And for that reason, the index of this session treat about the diagnosis, the prediction, the preventive measures, administration of corticoids, with all these speakers that Professor Roberto Romero has introduced before. Well, as we have short time for each one, for the big topic that they must be maybe develop, I will introduce, if you are agree, Roberto, the first speaker, because I have very sensible and familiar relationships with him, that is Professor Eduardo Gratacos, that is Professor of Obstetric Gynecology of the university and also the director of the Clinic San Juan de Déu Group. And one other thing that is also important, it's the editor of the Black journal, the Fetal Diagnosis and Therapy, that will present the prediction of preterm birth.
Thank you very much. I think I can start now. Thank you very much, Luis, for your kind presentation. Thank you very much, Roberto, as well, for introducing the session. And thank you to the presence of the Congress and the organization, Giancarlo De Renzo as well, for this kind invitation. And I'm going to share my screen right away, and I hope you can confirm that we see it well. And if yes, someone can tell me whether you see my screen. Yes. I will start right away. Okay, so I'm going to start. I have prepared a brief presentation because I look at the program and we were 5 speakers, so I hope I will not be running out of time. Prediction of preterm birth, and I have complemented the title with this second part in asymptomatic women, because I guess Tere Gobo, who speaks after me, will deal with this topic of how to deal with symptomatic women. It's a complex topic. Before that, let me just disclose this conflict of interest. I collaborate with one of the companies that develop softwares for the assessment of cervix. I'm going to talk very little about that, just a brief comment at the end, but I have to disclose this conflict of interest. So let's make a very brief introduction. And when we deal with prediction of preterm delivery, everybody knows what a preterm delivery is, but in reality, it's a syndrome. It's the failure of the natural physiologic mechanisms of pregnancy to bring this pregnancy to the desired term. And there are different reasons why this can happen. And when we look at spontaneous preterm delivery, which is the question of interest here, we see that it's not the same: late, moderate, severe, extreme. And we know that there is a clear association with infection in very early cases. Then we have a very big part of these idiopathic cases in which some of them have short cervices. And there is a myriad of postulated causes that try to explain why some women deliver before what we would like. There is this whole lifestyle issues. In some cases, the mechanisms might fail because we put them too much under stress. Of course, there's the very important contribution of multiplets. And very recently, we are also doing some fetal therapy that also increases. So it's really a very complex syndrome. So trying to predict a complicated thing is normally frustrating. And that is the reason why we have succeeded not so much, but some advances have been made. And that's what I will try to summarize very briefly in this presentation. So let's try to summarize which are the main arms of potential approaches that we could take. One is to say, okay, are there risk factors that really predict the problems in pregnancy? And yes, there are risk factors, and about 10% of pregnancies have some risk factor, and they account for in the range of 15 to 30% of all preterm births. And essentially, the main ones are previous preterm birth, miscarriage, multiple pregnancy, other risk factors. We will comment on very briefly. There is the second line of approaching the problem, which is, okay, let's look at the door. And if the door shows signs of getting a little bit open, might be that the things are not going to go well. We can do that by looking at the cervix or the cervical length by ultrasound, or we can look at substances, biochemical substances that come theoretically from the decidua and that are telling us that something is going wrong. And finally, there is this very well explored line of infection. This bacteriosis in reality, because in most cases it's not an infection, whereby microorganisms abnormally or in abnormally high concentrations could ascend and produce a problem. This is a very well documented mechanism. There is a clear association, but is there something that we can do for that? And that's something that we have not clarified yet so far. So I will mainly focus my presentation, of course, in the two main aspects that have shown clear use, which is the risk factors and the cervix, and I will briefly mention the others. So this is a very classical way of approaching, and it probably has not changed over the last maybe even 20 years. But the first important thing you can do to assess preterm labor is to do a good clinical history. And that's a topic, and it's nothing new, okay? And it's quite boring to say that, but that's it, and we have not changed that. So 10% of all spontaneous preterm birth happen in women with previous preterm delivery or miscarriage, and there is a clear increase. The earlier the previous preterm birth occurred, the higher the risk. So therefore, this is the most important question you have to ask any woman that comes into your consultation. How your previous pregnancy went, and if it went with a preterm birth, then you know that you are looking at a case with high risk. And this explains about 10% of these cases. Multiple pregnancy, again, 20%, they account in the range of 15 to 25, depending on the setting of all preterm births. And finally, we have a number of other risk factors that contribute, but if we have to take two that can change a little bit our practice, because we would really classify these women as high risk, and we could then look at the cervix, as I will explain later, then surgeries on the cervix or congenital uterine anomalies are the ones that are mostly agreed to represent a higher risk. So unfortunately, despite a lot of research, the highest proportion of cases is predicted by a good clinical history. Okay, let's go to the big advance that we have made over the last 20 years, which is the introduction of cervical length measure. Is the best predictor for spontaneous preterm delivery at less than 34 weeks. We know that there is a proportion of women that are going to have a short cervix. This changes depending on the population. It can range between 1% and 5%, but this is going to be a clearly increased risk. If you want to remember very, very simple numbers, and of course, there is not a mathematical number that works in all populations, but in reality, there is relatively fair concordance that if you have a cervix at mid-pregnancy of less than 50 millimeters, you're going to have 30% risk, and of less than 25 millimeters, 10% risk. So that means a multiplication by 10 or even 15. So it is the strongest predictor we have, and there is no question about that. Clearly, I'm going to very briefly discuss how that you have to do it well. You have to do it transvaginally, of course. It's very important to do training and standardization. And this is a typical boring aspect. Okay, everybody's talking about training and standardization, but it is critical. Look at the study we did in Barcelona before training and after training. The differences between two observers can be as high as 4 or 5 millimeters, and this is classifying a patient as low risk or high risk. This has been very well recognized in different studies, so I'm not going to stop here, but I think it's very important to mention before starting doing your cervical measurements, get a good training, because it looks like an easy measurement, and it is an easy measurement, but you need clear standardization. You need to measure the functional length. It is clear you need to measure the distance between the external and the internal O's. First studies mentioned that funneling could be useful, but we know that this is not the case. Sludge, this is not a good picture of sludge. I had another very good one that Tere Cobo gave me, but I didn't have time to put it in. But funneling, sludge, this sort of mud that you can find sometimes, they can work for women that are admitted with symptoms, but they do not work for screening purposes. So only this functional length of the cervix, you take at least 3 measures, you use the shortest one. And again, I'm repeating things that should be known, but again, I travel a lot in the world, not these days of COVID, of course, and I see many places where these measures are not respected and all this standardization. What is a short cervix? You can see different measures in different studies. There are very important studies that have been done with between 10 and 20, others that use less than 15. But in majority of societies, and if you want to use a simple number, there is an agreement on 25 millimeters, but this could be flexible depending on your setting. But if you want to have a reasonable and most commonly used number, this is 25 millimeters. It is also clear that if there are no risk factors, you do it just once, between 16 and 24. Some societies recommend 18 to 23. You can find variations depending on your region in the world, but this is a range that spans all applications. And if there is a high risk and previous spontaneous preterm birth, there is fair agreement that it may make sense to measure it serially, not only once. Only in these cases with high risk factors, could be also twins as well, could be uterine anomalies, and we will try to summarize at the end. But then you do it serially, and you can do it in the range of 1, 3, or even 4 weeks, depending on the risk factors. And then the big discussion where full sessions in congresses and even full days in Congress are dedicated to discuss, should we do it universally or not universally? The truth is that when you read the arguments in favor that it's cost effective, and this has been shown in different studies, it reduces preterm birth during universal screening because we have a treatment, and this is not going to be covered by me. I guess Professor Fonseca will deal with that. That's why I'm not saying anything about that. But there is clearly a treatment that reduces preterm birth, but the effect is small. Even if you are doing it very well, you're going to reduce in the range of 5 to 10% at most of all preterm birth. There's a big effort of setting up the programs. You have to train everybody if you want to do it universally. So there are investments, as mentioned, they are cost effective. But anyway, it can raise issues, and probably the fact that both proponents and opponents in a way raise somehow valid arguments explains why it is difficult to find a consensus in societies. So some societies like FIGO are more in favor and more clear in recommending this universal screening. Some others are not recommending this screening in recent editions. And I have just put 2 here, but I could have put 10. You can find 10 or 12 societies that makes somewhat in the middle statements that say, okay, it's not conclusively demonstrated, but if you want to do it, do it. And just to illustrate what I'm saying, read this very small paragraph that I extracted from the not so recent, it's 2018 recommendations of the, no, 2016, sorry, of the Society of Maternal and Fetal Medicine of the United States. Well, universal screening remains an object of debate. The current SMFM guidelines state that it cannot yet be universally mandated. However, it could be reasonable. So do what you want. And it's well, we all participate in consensus guidelines. And when we don't know very well how to say, we write these sort of sentences that say, okay, you can do it, but not. But if you do it, it's well. But if you don't do it, it's also well. And in the end, the main conclusion is if you have to do it, just do it well. And I think this summarizes the state of scientific knowledge that is non-conclusive. But I want to say as well that in reality, in most large hospitals, we are doing it. And that's the reality. We are doing this screening at universally. So a brief, and now I close the topic, and I have mentioned everything that clearly works. And okay, we have not advanced too much. No, we have not advanced too much. I mean, that's life. There are other things. Yes, fibronectin is an old molecule. Then we have others. This is just insulin growth factor, one of the examples, but you can find others. They are certainly useful because they really reflect the transition of these molecules that should stay here, and you should not detect them in the vagina. And they work, and in some applications, they work as good as the cervix, but they don't seem to work well for universal screening. They are not recommended. They, however, have great negative predictive value. So it is, they can be recommended, that they are used in some settings, for instance, to reassure patients. Just imagine that you have a patient with 2 previous preterm births, and then she has a cervix that is not too long, not too short, and then you can do fibronectins, and the fibronectins are negative, then you can reassure this patient that the negative predictive value is very high. This has not been assessed in a cost-effectiveness model, but this is an acceptable use, I would dare to say, but it's not for a universal use, all right? So this is the summary. I have spoken about risk factors, I have spoken about cervix, and I said nothing about infection, and I will summarize in a very brief comment that there is a clear association. This is an amazingly attractive line of research. At some moment of our lives, all those who have some decades of experience have investigated at some points in their lives, and I did as well, like 25 years ago, a lot of research on on bacterial vaginosis, and there is always a clear association, but when treatments are attempted, they fail to reduce the prevalence of preterm birth. It's a complex issue. So as of today, there is no recommendation to screen for these infections, which is a pity again, because there is a clear association, but no one has been able to show the way of screening for infections and reducing preterm birth. So we are left with risk factors, with cervix, and I want to summarize the current clinical practice that most societies would recommend is an integration of the 2 things that I just mentioned, assessment of risk, followed by cervical length. So when you have a woman before you, is the first visit, you look for risk factors. Did you have previous spontaneous preterm birth or miscarriage, which is also a very clear risk factor? Is it a multiple pregnancy? Obviously. Did you have cervical surgery, uterine anomaly? And then you end up with a yes or no risk factors. If there are risk factors, then you start doing your cervical length measurements a little bit earlier in pregnancy, and then you repeat them. If it's a very clear risk, then you could even do them every week if the patient has had 3 previous miscarriages and you think that there is cervical incompetency, and then you have to decide whether you do a cerclage or not. And this is something of course I am not entering, because Eduardo Fonseca will deal with that later. And if there is no risk, then you can do a universal screening in all women once only. You don't repeat it. At some point between 16 and 24, normally you could do it at 20, because this is a timing when you are going to do your morphological scan. Of course, we have to mention the caveat that you could do nothing, of course, because there is no universal consensus. So if you, in your setting, are not doing universal screening, probably you are not doing something that societies strongly recommend. But if you are doing it, you are doing what most people do. And that would be the summary. And I think as for clinical practice, we are left here, and I'm just going to dedicate 1 or 2 more minutes to say, okay, and is there something coming up that could improve? Because we are looking at the cervix, we are looking at the length. We have tried if the funneling was okay, but it's not working to predict. But when one looks at one of these cervices that is being shortened, you appreciate that the cervix has a different consistency. And that's something that all clinicians have appreciated for many years. So at some point, people said, okay, would there be a way to make more objective this assessment of consistency? Could we look at the features of the cervix? Because before getting shorter, the cervix must change consistency. That is why it gets shorter. Otherwise, it would not get shorter. So it gets, let's say, softer, it gets more flexible, more elastic. Why don't we try to look at that? So several lines of research have tried to look at the cervix, not only measuring the length, but measuring the consistency of the cervix. This is the Cervical Consistency Index that was proposed by Miguel Parra in Colombia, and several groups have evaluated it. This is elastography, a technique that uses, well, it's not developed for the cervix, of course, it's developed for many other uses. So you measure the elastic properties of the tissue, and this is texture analysis that looks at the properties from a quantitative computed analysis. All these techniques have shown some promising results, but they are all awaiting validation in clinical studies. We particularly have been working with this texture analysis. This is a technique that was developed here in Barcelona, but then was licensed to a company, and they are looking for applications. And this application of trying to look at the consistency of the cervix is very appealing, is attractive. Why don't we use a computer? You delineate automatically the cervix, and then you analyze several patterns that you try to train with machine learning. And then this is a paper that we are going to publish now. So initial results look very promising because it performs much better than cervical length. But as you know, these initial studies have to be confirmed in large-scale studies, and we are preparing a multi-center study that will start very soon, and we hope to see whether this is the case or whether it's not. But the notion that I would like just to leave is that maybe in the future we can have better techniques than cervical length, and maybe we could find more women to give progesterone or whatever treatment, and that could benefit more women if we are succeeding in these purposes. So to summarize current knowledge and to be very practical, when you want to be very practical, you end up with a sentence. And if you want to do good prediction of spontaneous preterm birth in asymptomatic patients, you have to combine risk factors, as we have mentioned, previous delivery, miscarriage, twins, surgeries, or uterine anomalies, and you combine it. And then in those women with risk factors, you do serial cervical length. In those women without risk factors, you can do nothing, but most of us do cervical length at 20 weeks of gestation. And who knows, maybe in the future, we can use models that integrate risk. There are several described, and as I have mentioned before, we need more evidence to see if by combining we can improve, and maybe by computerized models we can improve our prediction. But as of today, this is what you really should do. If you don't look for risk factors, you are not doing good practice, and you have to integrate cervical length in your practice. This is doing good practice, evidence-based practice, and then you can avoid instances of preterm labor and change the life of many people every year. Thank you very much for your attention.
Thank you very much, Edward, for this very interesting session, specifically also for the clinicians. Well, the next is, because we are prepared one time at the end to do the general discussion, but if you can see in your screen, there are one place that you ask questions and answers. You can check there, and if you see any question for you, you can answer directly to the people that are asked for you something. The next speaker, Roberto, if you can introduce you can introduce the second speaker. Roberto?
Yes.
Okay, thank you very much.
Excellent. So thank you, Edward. The next speaker is going to be Teresa Cobo, also from Barcelona, Spain. Teresa has done great work in assessing the patients who present with an episode of premature labor, and she's going to address the issues of diagnosis and the workup of the patient presented with an episode of premature labor. Teresa, thank you for joining us.
Thank you to invite me, Professor Romero. I'm going to talk, as Dr. Gratacos said before, I'm going to talk about the symptomatic women, and I'm going to do an update about the diagnosis of preterm labor. I'm going to start with a clinical case. I'm presenting to you Anna. Anna, she's 39 years old. This is her first pregnancy under an IVF process, and she's at week 25 of gestation and came to our emergency room because she feels that she's contracting. And you can see in her CTG that it's true that at least we can record 4 contractions in 10 minutes. And then I also want to present Angel. Angel is a resident. He's in training in the 2nd year. And he comes to me, that this is me, when I will be 50. and comes to me and tell me, Teresa, I have a woman in preterm labor. I think we need to talk with our neonatologist. We need to administer steroids. We need to give a magnesium sulfate because this woman is going to deliver. And I tell him, why, Angel, do you think so? Oh, yesterday I read NICE guideline. And in UK, if you have symptoms of preterm labor and you are less than 30 weeks, women are treated. Because Teresa, you know that preterm birth is a really complex problem. And you know neonatal consequence of being born preterm. And it's not the same to be born at week 24 than to be born at week 37. And Anna is at week 25. So I think she's going to deliver. And neonatal consequence of this extreme premature is very important. And you also know, Teresa, that we have a chance for this baby because if we are giving antenatal steroids, we are improving his perinatal outcome. And of course, we also have to give magnesium sulfate because it has been shown that it reduces the rate of cerebral palsy in these premature babies. And I told him, okay, Angel, you really did very well, but you need to know that only 10% of women who are contracting and who come to a emergency for symptoms of preterm labor will deliver in the following 7 days. So majority of these women, more than 70%, will deliver above 37 weeks. So I think, Angel, that we don't need to treat in a similar way to everyone, but we need to target the risk. So it's important to discriminate who is the really high-risk group to deliver in 7 days, because in this group, we really need to do all our efforts. However, the 70% of women who are going to deliver above 37 weeks are unnecessarily treated according to your protocol. And it represents a social cost because of anxiety, medical leave, and medical costs, because some drugs, as you know, with nifedipine, can have side effects to the mother, to the women, and also an economical cost. And we need to take this into account. And don't forget that there is also long-term effect. And of course, antenatal steroids work perfectly well if the baby is going to deliver preterm. However, if at the end the mother is delivering near term, you know that there is a negative influence of these steroids, and there is a negative influence on the birth weight. It has been observed higher risk of hypoglycemia. There is an impact on neurodevelopmental outcome, and in adolescents, there is a higher risk to be hypertensive and also to have insulin resistance. So take this into consideration and try to target the high-risk group and not only to be based on the symptoms. And for this purpose, there are different tools that we can use. You know that one of them is the cervical length. The shorter the cervix, the higher the risk. But you also need to know that physiologically, it's normal that the cervical length will be shortening along gestation. So this is why there is proposed different cutoffs according to gestational age. So if we are in an early gestational age, as Anne is 25 weeks, maybe we need to use a conservative cutoff because we want to detect all the preterm birth. We don't want to miss any premature baby. We need to use a high sensitivity. However, if we are above 34 weeks, maybe we don't need to be so strict. Of course, we are worried about premature consequence, but at week 34, there are not major neonatal outcome. It's really rare. So at this point, in a late gestational age, it's most important not to overtreat unnecessary women. And in this case, we can use a less conservative cutoff, such as 15 millimeters. But when there has been evaluated whether these ultrasound tools, the performance and ultrasound in symptomatic women, if improve perinatal outcome, there has been shown that the performance of an ultrasound cervical length in a woman with symptoms of preterm labor only reduced the rate of preterm birth less than 37. It doesn't have any influence in preterm delivery less than 28, 22, 32, 34, and it doesn't improve neonatal outcome either. In our case, we performed an ultrasound cervical length in Anna, and the cervix was extremely short. It was 6 millimeters. So if these ultrasound scans are not available in your clinical setting, there is something that looks like quite similar, with similar accuracy, and they are the biochemical tests. There has been described a test who measured the placental globulin, the fetal fibrinogen, the insulin growth. It doesn't matter. You see that they look like quite similar. And if we wear them, it seems that placental globulin could be better, have a better diagnostic performance, but they are quite similar and quite similar to cervical length. And the same as cervical length. Okay, we can do a fibronectin. However, there has not been shown that to perform a biochemical test in women with symptoms of preterm labor will improve perinatal outcome. However, we believe that it helps to the clinician in the clinical decision making to be sure if this woman needs to be admitted to hospital or not. So this is why in NICE guideline, they don't comment anything about ultrasound or biochemical tests in women less than 30, but in women above 30 weeks of gestation with symptoms of preterm labor, they recommend to use ultrasound, cervical length, or biochemical tests. In our clinical setting in Barcelona, we always decide to admit a woman based on symptoms, but also based on ultrasound cervical length. But we can go further because nowadays there has been proposed different multivariable predictor models, and we can upload them in our mobile phone. So they are like an app and they are free of charge. And in these predictor models, we can add information about the mother, about the prior history of preterm birth. We can add information about cervical length. There are different examples. They come from Europe, but I guess that in US, there must be something similar. And they give you a final risk. And these tools can also help us in the clinical decision making to decide to admit or not a woman with symptoms of preterm labor. This slide is really nice. You can see here the policy according to the NICE guideline. In UK, all women below 30 weeks with symptoms of preterm labor are treated. So of course, sensitivity is 100%. They detect all the cases, but they need to admit all women. If you apply a predictor model similar to QUIP, let's see, it doesn't matter the risk that you will decide, that you assume. You keep the same sensitivity, so you are detecting the same preterm birth. However, let's see here, because you are avoiding almost 80% of admissions to hospital, and this is really important. These authors, the Shinen group, are now prospectively going to evaluate whether the implementation of this QUIP in the clinical management of a woman with preterm labor has an impact on the prenatal outcome. And it's a paper it's a study that is going on. So let's see in the future the results of this NICE study. In our case, we only performed the cervical length. We didn't use the QUIP app. And in this case, that there was 25 weeks, she was contracting a very short cervix, we decided to admit Anna to hospital and to start with the treatment of preterm labor. But then I asked again Angel, are you really sure that she's going to deliver in 7 days? And then let's move to the picture of Professor Romero. This is how complex is preterm birth. You know that there are multiple etiologies, and one of them we don't need to leave. That one of them is the infection. An infection is important, mainly at early gestational ages, below 32 weeks of gestation. And Dr. Romero has described 4 phenotypes of women. There are women who have infection and inflammation. There are women with only infection. There are women with only inflammation. And there are a group of women with preterm labor, without infection and without inflammation. And what's the clinical relevance of this? The clinical relevance is that this group of women are those with an early onset of symptoms. Anna is 25. In this case, we need to suspect an infection and inflammation. And in this group of women, one of the clinical relevance is that this group is associated with a really short latency to delivery. Let's move to our results. They come from Hospital Clinic in Barcelona. So you know that we perform amniocentesis in women with preterm labor to rule out for infection and for inflammation. And this is our policy to admit a woman. We admit a woman a preterm labor based on symptoms, based on gestational age, and also based on ultrasound cervical length. And as you can see, almost all of our women agree to perform an amniocentesis for this indication. There are 70% of women who did not consent. In these women, we test for markers of infection and inflammation, and I will talk later about that. And they are the distribution of the phenotypes of Dr. Romero. You can see here that below 32 weeks, 40% of our women have infection or inflammation, and there are 60% of women who doesn't have neither infection nor inflammation. But what's important, let's see here, latency to delivery from admission to delivery was very, very short in this group of women. And let's see here, in this group, the latency to delivery was 50 days. Do you think that this group really benefits from these antenatal steroids? Who is the really high-risk group to deliver preterm, to deliver in the following 7 days? Is this group. The problem is that to identify this group, we need to perform an amniocentesis. And this is an invasive procedure. And this is what limits the clinical translation of this procedure. But let's see here, this is PPROM, the rate of complications in women who have oligohydramnios. The rate is very low. So we believe it's a safe procedure because they are women at third trimester of gestation, and in case of preterm labor, they are women with intact membranes. And the day of the duty, in the following 1 hour, we can have infection, we can have information about infection and about inflammation. We don't need to wait for the culture in 3-4 days. The same day we can have information because we can test for glucose. And maybe you will tell me, oh, Teresa, glucose, it's an old-fashioned marker. You see that all the reference and the last century, they are not new reference. Yes, it's true, but it's very cheap and it's really available in most of clinical setting. And you can have the result in 1, maximum 2 hours. And let's see here, the high specificity. So very low false positive rate. It means that if the glucose is low, it's because there is a likely chance to have an infection. And similar with the gram. The inconvenience of gram is that the sensitivity is not very high. But this is because the most common microorganism isolated in women with intraamniotic infection is the ureaplasma. And ureaplasma is a very little bacteria and is not seen in a gram stain by the microbiologist. This is why the sensitivity is not very high. But let's see here that there are tests that are available in our hospitals and the result can be obtained in really few minutes, 1-2 hours maximum. And the same happened with interleukin-6, reported classical biomarker of intraamniotic inflammation. Today, we are able to test for interleukin-6 and we are able to have the result in few minutes, in 40 minutes. So the day of the admission, the day where we perform the amniocentesis, we can have available information about infection and about inflammation in this woman. But we can go further, and this is what we did at Hospital Clinic. So similar to Down syndrome, similar to this QUIP app, we try to develop and also to validate a predictor model for MAIAC and also for spontaneous preterm delivery in 7 days. And let's see here, the best variables that predict the presence of MAIAC were glucose and maternal CRP. We did the same for spontaneous preterm delivery in 7 days. And we observed that gestational age, cervical length, amniotic fluid glucose, and interleukin-6 were the best biomarkers who match with the outcome of spontaneous preterm delivery in 7 days. And we developed the model and we also validate. And you can see the performance, diagnostic performance in both cases are quite good. And a good example is this. Let's see here. So a woman with preterm labor, less than 32 weeks. We have said that almost 22% of women with preterm labor and intact membranes have an infection. So the priority risk of a woman with preterm labor less than 32 weeks is 22. So if we apply our test and the risk is high, the test is positive, let's see here, our prediction increased to more than 70%. And if we apply the test and the test said that there is low risk, then this risk, this priority risk, decreased to 6%. And something similar happens with spontaneous preterm delivery. In our case, the priority risk is quite high because we really select those women who need to be admitted. So we don't admit all women with symptoms, only those with a really short cervix and who are contracting. So we really are quite good only with the clinical examination to really predict the outcome of spontaneous delivery in 7 days, because our prevalence is quite high, almost 60%. But if we apply our test and it tells us that there is a high risk, you see that the risk increase to almost 80%. And the same, if we apply the test and it says that it's a low risk, from this 60, we decrease to 20%. So it could be useful. In our case, we performed an amniocentesis to Anna, and glucose was 3, very low. Interleukin 6 was high, and maternal CRP was slightly high as well. So when we test our predicted model, the risk of spontaneous delivery in 7 days was very high, 90%, and the risk of infection was 85%. So with this information, we could make a plan. We could call our neonatologist, we can start with antibiotics, we can be prepared because the delivery seemed to be quite soon. But we understand that one of the things that maybe has limited the performance of an amniocentesis for this indication is that we have not shown that the amniocentesis in a woman with preterm labor will improve the perinatal outcome. And I think that this is one of the reasons why most of clinicians are reluctant to perform an amniocentesis for this indication. So I think that it's time now. I think it's time now just to try to answer this question. We don't know if we are going to improve perinatal outcome. Maybe not, because the highest group, you know that the latency to delivery is very short, so we don't have enough time to treat them and to improve their outcome. However, we believe we can optimize the antenatal management of these women with preterm labor, because if we identify this group, maybe in this group, we don't need to do all our overtreatment that results to be unnecessary, because these women are going to deliver quite late in gestation. So we aim to start with a randomized control trial quite soon. We are almost finishing all the papers. This randomized control trial is going to call Optim Preterm Labor, Optim PTL, and there will be 2 branches. In one of them, there will be the standard management in most of clinical settings to manage preterm labor without information of amniocentesis. But in the other arm, we are going to apply this predictor model of infection and spontaneous preterm delivery that includes amniotic fluid glucose and also amniotic fluid interleukin 6. So it includes information from an amniocentesis. And let's see what happens. Our aim is to reduce the number or the doses of corticosteroids in this group without worsening the prenatal outcome. And also our aim is to try to reduce the stay length of this mother without worsening the maternal outcome. So finally, as conclusion, I hope that you have understood that we don't need to treat everyone in a similar way. We need to target the high-risk group, because it's the high-risk group who needs all our efforts, but the low risk maybe are unnecessarily overtreated, and it can have an effect in the long term. Thank you so much. Dr. Cavero, I think that no one can hear you.
I'm sorry. Now, yes? Yeah. Congratulations, because you are presented a very nice paper and a very nice information for the clinicians. Roberto, you want to present your very good friend, Eduardo Fonseca, please?
Sure. Teresa, congratulations. It's an excellent talk. Great insights and contributions. And it's a great pleasure to introduce Eduardo Fonseca, one of the leaders in the prevention of preterm birth. He rekindled the interest in progesterone, and he's a very enthusiastic speaker. So Eduardo from Sao Paulo, Brazil, welcome. Thank you for agreeing to speak to us today.
Thank you, Roberto. Thank you, Giancarlo, for the invitations. I'm proud of being in this group, and you and Giancarlo are giants who know how to make happen. So today, I'm trying to speak the role of progesterone, pessary, and cerclage for the preventions of preterm birth. In the strategy for the prevention of spontaneous preterm birth delivery, we have now at least 3 weapons: progesterone, pessary, and cerclage. Here, it's not the question what is the best treatment, but is the questions of more effective treatment we have for the right patient. So, as you know, the 3 most important risk factors for preterm birth is the prior history of preterm birth. The second risk is twins, and the third risk factor is short cervical length. Here, I'm going to speak more about short cervix at scan. Firstly, because it's the best way to compare progesterone, pessary, and cerclage. And secondly, because transvaginal scan, cervical length, is the most powerful predictor for preterm delivery in the current pregnancy. Prevention with progesterone, pessary, or cerclage. We need to have we need to bear in our minds that the risk factors sometimes is in the associations with others. For instance, I have a patient with short cervix. In the majority of cases, the short cervix is the only risk factor. But sometimes we could find a patient with twins and short cervix. So it's important to understand that we need to put in account the numbers of risk factors and then to find the most effective treatment. I'm trying to split these presentations in 2 sets. I'm speak firstly for those with twin pregnancies, and secondly, I'm going to speak for the preventions in those with singleton pregnancies. So the first study that caught our attentions for the effectiveness of progesterone in the improvement of perinatal outcome in twins was published in 2015. And in that study, they found that neither 17-hydroxyprogesterone or vaginal progesterone reduced the incidence of adverse perinatal outcome and the incidence of preterm birth in an unselect group of twins pregnancies. However, in a subgroup with patients with a short cervical length equal or less than 25 millimeters, vaginal progesterone reduced preterm adverse perinatal outcome in about 43%, and the author's conclusions was vaginal progesterone may be effective in the reductions of adverse perinatal outcome in women with a cervical length of 25 millimeters. Of course, further research is needed to confirm this finding. A couple of years later, Roberto Romero brought this paper, this IPD meta-analysis, where 6 RCT with 300 women and 600 infants was evaluated, and he found that vaginal progesterone in asymptomatic women with twin gestations and mid-trimester short cervical length reduce the risk of preterm birth occurring at 30 to 35 weeks, and reduce as well neonatal mortality and neonatal morbidity. Just a couple of months ago, the FMF group brought this study published in the American Journal of Obstetrics and Gynecology, early vaginal progesterone versus placebo in twin pregnancies for the prevention of spontaneous preterm birth, a randomized double-blind trial. So they select about 1,100 patients where vaginal progesterone 600 milligrams per day or placebo from 11 to 14 weeks to 34 weeks was administered. And the target was the reduction, the primary outcome was the reductions in the incidence of spontaneous preterm birth between 24 and 36 weeks. So after excluding birth before 24 weeks and elective indicated deliveries before 34 weeks, spontaneous birth between 24 and 34 weeks occur in about 10% in the progesterone group and in about 8% in the placebo group. There was no evidence that chorionicity could play a risk factor in this group, and there was a weak evidence of intervention of the cervix length, suggestive that the long cervix, longer than 30 millimeters, was harmful if you take progesterone, and if you had a cervix shorter than 30 millimeters, progesterone had benefit. So the conclusion of the study was in twins, vaginal progesterone did not reduce spontaneous birth less than 34 weeks. However, post-hoc analysis led to the suggestions that progesterone may reduce the risk of spontaneous birth less than 32 weeks in women with short cervix less than 30 millimeters, and this is important, it may increase the risk for those with cervical length longer than 30 millimeters. Therefore, we know that it's important to go for RCT specifically for those twins with short cervix than less than 30 millimeters. But in my point of view now, the most important thing is in this group, twins, is important to have a cervical assessment. And for those with long cervix, it's important to avoid any treatment. So let's see now pessary in twins and short cervix. From this study, published in the American Journal of Obstetrics and Gynecology, where cervical pessary for the prevention of preterm birth in twins was evaluated. In this post-hoc time to event analysis of 214 twins with short cervix, the conclusion was that in twins does not insertion of pessary at 21 and 23 weeks does not reduce the rate of preterm birth, neither perinatal death or neonatal morbidity. So the rate of preterm birth in the pessary group with short cervix and twins was about 30%, and in the group that doesn't have pessary was about 26%. So in this study, the intervention pessary group increased the risk of preterm birth in the same way that to give progesterone for twins with long cervix increase the risk as well. In 2016, the Barcelona group, by the leadership of Maria Goya, published this paper in the American Journal, where 134 twins was evaluated to check the benefit of cervical length in the prevention of preterm birth. In this study, they found a reduction from 39% in 68 patients who didn't have treatment, for 16% of birth less than 34 weeks in 68 patients who had the insertion of pessary. And the conclusion was that the insertion of cervical pessary was associated with a significant reduction in the spontaneous preterm birth rate. We propose the use of cervical pessary for prevent preterm birth in twins of mothers with short cervix. Few months later, Gabriele Saccomi brought this meta-analysis published in the Journal of Maternal and Neonatal Fetal Medicine, where 3 RCT, 481 women and 600 infants was included. And for delivery before 34 weeks, 2 studies has demonstrated that there was no reduction in the preterm birth by the insertion of cervical pessary. And the conclusion of Sacconi was Arabian pessary in twins with short cervix at 16-24 weeks does not prevent spontaneous preterm birth or improve perinatal outcome. Of course, RCT are need to clarify these studies' conflict results, because there are studies that demonstrate a wonderful results, a wonderful perinatal outcome, and other that doesn't find any difference. Cerclage in twins, does not prevent preterm birth in asymptomatic twins with a maternal short cervical length on transvaginal ultrasound. There are 3 studies, and again, Gabriele Sacconi in the Acta Obstetrica and Gynecology in Scandinavia, 2015, demonstrate that by using cerclage for patients with short cervix in twins, the risk of preterm birth was 2 times higher, with a 95% confidence interval from 0.7 to 6.6. So to use cerclage in twins is harmful. Let's move on now for singleton. Let's see pessary, cervical pessary in pregnant women with a short cervix. This was an open label randomized control trial where 385 patients was split to receive pessary or expectant management. And in this study, the Barcelona group has demonstrated and published in the Lancet 2012 a reduction in the rate of preterm birth from 26.8 in the expectant group for 6.3% in the pessary group. And the conclusion was pessary prevent preterm birth in a population screening for cervical length assessment at the mid-trimester scan. 4 years later, the FMF group brought this huge study with almost 1,000 singleton pregnancies, where it split 466 to receive pessary and 469 to expectant management, and the rate of preterm birth in both groups was quite similar, about 11-10%. And the conclusion of this study was in singleton with a short cervical length insertion of pessary at 20-24 weeks does not reduce the rate of preterm birth, does not reduce perinatal death and morbidity. In 2017, again, Gabriele Sacconi has brought this meta-analysis published in the Journal Ultrasound Medicine, where 3 studies was evaluated, and the primary outcome of these studies was spontaneous preterm birth less than 34 weeks. So with almost 1,400 patients, 700 in pessary groups and 700 in no pessary groups, the conclusion of the meta-analysis was in singleton pregnancy with a transvaginal ultrasound cervical length equal or less than 25 millimeters at 20-24 weeks plus 6 days, the Arabian pessary does not reduce the rate of spontaneous preterm delivery or improve neonatal perinatal outcome. Of course, IPD meta-analysis may clarify whether cervical pessary may be beneficial in a subgroup such as only singleton without preterm birth or by different cervical length cutoffs. And just a few months ago, Conde Agudelo, Agustin, Roberto Romero, and Kipros Nicolaides brought this meta-analysis with 12 RCTs, including 4,687 patients, 7,167 fetus or infants, and there were 3 different kinds of studies. 8 studies evaluate pessary versus no pessaries in women with a short cervix. 2 assess pessary versus no pessary in unselect multiple gestations. And 2 compared pessary versus vaginal progesterone in women with short cervix. And here are the conclusion. The evidence does not support the use of cervical pessary to prevent preterm birth or to improve perinatal outcome in singleton with gestation, in singleton or twin gestations with a short cervix and in unselect twin gestations. And they compare the subgroup of progesterone. Women who did not receive vaginal progesterone, there are 1, 2, 3, 4 studies. There was no reduction in the rate of preterm birth in the pessary group. And women who receive vaginal progesterone, there was no reduction. So progesterone does not interfere in the pessary. So the good benefit maybe that they could find is by adding progesterone, but progesterone does not change the result of pessary in the patient with short or unselect risk group. And the conclusion of the meta-analysis just published was evidence indicates that cervical pessary does not prevent preterm birth nor improve neonatal outcomes in singleton gestations. And what about cerclage, singleton and short cervix? The first paper was published by, again, FMF group by the leadership of Miketo, where 470 patients with short, very short cervix, equal or less than 15 millimeters, were split for cerclage or expected management, and the conclusion was the insertion of Shirodaka suture in women with a short cervix does not reduce the risk of early preterm delivery. And finally, progesterone for short cervix. We have 2 main studies. The first one was from the Fetal Medicine Foundation by the leadership of Kypros Nicolaides. And the second one was from the PRB by the leadership of Sonia Hassan. And both of them has demonstrated that the use of vaginal progesterone, either pessary or gel, reduced the rate of preterm birth in about 45%. And this reduction was translated in improvement of neonatal morbidity and mortality. In 2018, again, Romero brought this meta-analysis, IPD meta-analysis with 5 RCT, nearly 1,000 patients, and he was able to demonstrate in this meta-analysis that perform universal transvaginal cervical length screen at mid-trimester in women with singleton gestations, and offer vaginal progesterone to those with short cervical length is important in order to reduce the rate of preterm birth. And now the question is, shall I use cerclage or progesterone for those with singleton and short cervix? We know that cerclage and vaginal progesterone can reduce the risk of preterm birth in a specific group of women at very high risk. Those with all of the 3 of follows risk factors: current singleton pregnancy, last prior spontaneous preterm birth, less than 34 weeks, in short cervix, less than 25 millimeters, less than 24 weeks in the current pregnancy. If I'm not going to do anything for this patient, the rate of preterm birth is going to be about 20% for birth less than 28 weeks and about 30% in for birth less than 32 weeks. And in this IPD meta-analysis published in 2018, where vaginal progesterone appears to be as effective as cervical cerclage to prevent preterm birth in women with singleton gestations, prior history of preterm birth, and short cervix. So this is a indirect comparison meta-analysis, has demonstrated that vaginal progesterone versus placebo and cerclage versus no cerclage reduce the rate of preterm birth. And when you compare both of them, they are similar. So the conclusion of this indirect meta-analysis is that vaginal progesterone and cerclage are equally effective for preventing preterm birth and improving perinatal outcome in women with singleton gestations, prior spontaneous preterm birth, and short cervical length at 20-24 weeks. Of course, the choice of treatment will depend on adverse event and cost effectiveness of intervention, and of course, patient and physician's preference. So the take-home message is, in the strategy for the prevention of spontaneous preterm birth, we need first select the risk factor: prior history of preterm birth, twins, and short cervix at 20 weeks, less than 25 millimeters. For those with prior history of preterm birth, we believe, in agreement of the FIGO, that cervical assessment for reassuring pregnant women and progesterone for those with short cervix could reduce the rate of preterm birth. And then we can use progesterone 200 milligrams daily till 34-36 weeks. For twins and select twin gestations, we have to consider cervical assessment. Once those with long cervix, the use of progesterone could be harmful. And for those with short cervix, progesterone could be used 200 milligrams daily or 200 milligrams twice a day until 34-36 weeks. But of course, we need to push for RCT to demonstrate the good benefit of progesterone in the IPD meta-analysis and to confirm the suggestions of the harmful of progesterone for those with long cervix. And finally, for those with short cervical length, progesterone, micronized progesterone, 200 milligrams daily till 36 weeks. Thank you.
Thank you very much, Eduardo, for this very synthetic and nice presentation. I think that will be at the end some discussion about the pessary and about the other suggestions that you are made in your presentation. Now it's a pleasure for me to introduce the next speaker, that is Jerry Visser from Netherlands, from the University of Utrecht, who will explain or will present the title of Corticosteroids, Controversial Issues, Late Gestation and Repeat Treatment, that he will discuss all these topics. Roberto, you want to say something about that?
I would like to welcome Jerry. Let's keep the session moving. And I think we're having a very exciting session. Jerry, thank you for joining us. Thank you, Luis.
Thank you. Jerry, you can begin.
And thank you very much for having me. I guess I have some problems. I have the slides in front of you.
No?
I use the share screen.
I don't know if there are Fabio.
Yes,
yes, you can help to Professor Visser.
Yes, Professor Visser. Are you on Zoom or are you seeing the PowerPoint?
I'm on Zoom. I had my PowerPoint. I now have.
Can you see the green button, the share screen button?
I don't see the share screen button.
It's at the bottom of your screen.
Zoom.
Otherwise, I can launch your presentation if not.
Yeah, I'm on my way.
Do you have one image at the bottom of your screen in order to put more than one screen?
The technical assistance has now arrived, so...
Over here, minimize video.
There is a green...
Is it possible that you don't have him allowing to share a screen? No, over here, share screen, there it is.
But I used it already.
Yes, let's share. And let's start the presentation.
Yeah, that's okay.
Thank you.
Ja, nee, dan ga ik naar deze nog. There we are, or not?
Okay.
Apologies, but I came from one Zoom meeting to the other one. It's a busy day this early October. Thank you very much, Professor Romero, Professor Di Renzo, for participating in this very interesting workshop. Corticosteroids. First randomized controlled trial was published in 1972, 48 years ago, and still there are controversial issues. And the most important ones, the ones that I will discuss, should we give them in later gestation, and what about repeat treatment? First of all, I'd like to emphasize that corticosteroids do work when given before 34 weeks of gestation. At this moment, there are about 30 randomized controlled trials who have shown that. And the importance of this slide is to illustrate that they worked in the 1970s, in the 1980s, and in the 1990s. And that's very important because in the 1970s, when the first trials were published, there was in fact no neonatal intensive care yet. There was no surfactant, nor was there any high frequency ventilation. But also with modern neonatologies, you can see antenatal steroids reduce neonatal deaths by about 50% and almost similar percentages for RDS and periventricular hemorrhage. Also, follow-up after one course of steroids is reassuring, and that holds for studies at the age of 6 till studies at the age of 30 years, apart maybe from an increased insulin resistance. Later on in life, we do not know yet, but until the age of 30, I mean, they're very reassuring. Why are there then these controversial issues? Should we give them in between 34, 37 weeks? And should we repeat them? That's taking into account the potency of these drugs. And it's usually like that. If drugs are potent, they usually also have potential, at least, potent side effects. And as far as corticosteroids are concerned, it has been shown that they reduce placental weight, studies in the human. They cause a reduced fetal growth velocity and weight and height at birth, both in animals and in the human. A reduced head circumference with dominant effect in the hippocampus area, both in animals and in the humans. And to show a few of these data, here is the mice 3 days before delivery. Corticosteroids were given, and you can see that there is immediately an enormous decrease. This is normal. A decrease in the number of proliferating cells in the hippocampus and an increase in apoptosis, so cell death and no new cells being formed. Fortunately, after birth, you can see there is an increase in cell proliferation, maybe to limit the damage that had occurred beforehand. But when these mice are grown-up adults, you can see there's a much lower number of proliferating cells. And these are, when you're grown up, essential in the hippocampus, at least in mice. And what are the consequences of that? That there is an impaired learning and memory after treatment prenatally with corticosteroids. If you look at the liver, there is fibrosis as compared to control. If you look at the heart, there is a degeneration of myocytes as compared to control. So there we are, mice being treated prenatally with corticosteroids. They induce a precocious aging, and to reduce lifespan, they die about 30% earlier than mice not being treated prenatally with corticosteroids. Well, fortunately, humans are not mice. For instance, we don't have a tail. But if we go to another animal with a tail that's a little bit closer to the human, the monkeys, then you can see that also if monkeys are being treated prenatally with corticosteroids, there is a reduction in neurons in the hippocampus. At 9 months of age, higher cortisol levels, and at the age of 1.5 years, there is a 30% reduction in the size of the hippocampus. These effects are dose-dependent, but also in the doses given before birth, effects were found. So maybe these side effects may also appear in the human. And here you can see the hippocampus in the human, and on the right side, these fetuses had been treated with corticosteroids, and you can see a lower density of neurons. And here you can see the study that we conducted, 22 neonates. Within 4 days after delivery, if you look at the number of neurons, large neurons in the hippocampus, it was significantly lower after antenatal corticosteroids as compared to no steroids. Of course, this is not a randomized study. These were 22 infants delivered between 25 and 32 weeks who died within 4 days after delivery. And by chance, half of them had been treated prenatally with steroids and the other half not. So the proof is not as strong as it is in animal studies, but also this suggests that antenatal steroids have an effect on the human hippocampus. Neonatologists also know about the side effects. Early neonatal treatment with corticosteroids has some good effects. A lower incidence of chronic lung disease, retinopathy, etc., all 20% lower. But if you look at gastrointestinal bleeding and perforation, hypertension, hyperglycemia, cardiomyopathy, growth failure, cerebral palsy, abnormal CNS examination, all 1.4 to maybe 2 times higher following neonatal steroids. Here I must say that the doses given neonatally were usually higher than the doses that we are giving prenatally, but it shows the potential harm that may induce by corticosteroids. There is a meta-analysis on studies that compared one course of steroids with repeated corticosteroids. In this case, repeated means weekly these courses were repeated. And you can see if you repeat corticosteroids, that short-term outcome is somewhat improved. Lower incidence of RDS and severe composite morbidity. But if you look at birth weight, head circumference, height at birth, weight, they were all lower in the corticosteroid group, with no difference in total deaths and to survival, free of any major disability or serious outcome later on. So if you repeat steroids, yes, short-term outcome might be a bit better, but this is a bit worrying, isn't it? The MAX trial was not included in this meta-analysis, this trial from Canada, since they repeated corticosteroids every 2 weeks and not weekly as in the other trials. But this was by far the largest trial, altogether 2,300 inclusions, no benefit at all on outcome. And if you look at birth weight, it was about 100 grams lower in the repeated steroid group. Length at birth was 0.9 centimeters smaller, and head circumference was 0.6 centimeters smaller. And we have to emphasize that head circumference means size of the brain. So the brain is smaller after repeated corticosteroids. There is a follow-up study of this MAX trial 5 years later. There was no differences in 5-year outcome in the infants born preterm, but 1/3 of these infants were born at term, and we can see that for the infants born at term, there was a significant higher incidence of death and or neurodevelopmental disability. And if you look at neurodisability, it was about 3-fold higher. Why no effect on infants actually born preterm and those born at term, we don't know. So what about it? Should steroids be repeated? If you think so, then give only 1 single repeat course, not more. Also the advice of the WHO. And only before 32 weeks of gestation, because all the trials have shown no benefit at all if steroids were repeated after 32 weeks of gestation. But most importantly, take cervical length and fibronectin into account when deciding to give steroids or not. And that was also very nicely illuminated by Teresa Koba earlier on during this session. Yes, we give too many corticosteroids, also in women who don't need it, and that can also be shown by this publication of a year ago, a population of 25,000 term deliveries, and 3% of the babies born at term had been treated with steroids before 37 weeks. Unnecessary. You can also see that the incidence of small foedates was almost twice as high in these infants, but it's uncertain if it's due to the steroids given beforehand or to adverse factors leading to preterm contractions, maybe placental insufficiency. So corticosteroids at 34 to 37 weeks, should we give them? We have to realize that that would result in a more than doubling of the use of these drugs, since there are more preterm deliveries after 30 weeks than beforehand. There is this beautiful randomized controlled trial from the United States, published in the New England Journal in 2016. Antenatal betamethasone for women at risk of late preterm delivery. Large study. If you look at severe adverse outcomes, syndromes, or treatment with ECMO, stillbirths, RDS, there was no significant difference between the different groups. But if you combine symptoms like CPAP, oxygen, mechanical ventilation, it was 20% lower in the betamethasone group. And similarly, if you combine RDS with tachypnea, apnea, it was 13% lower in the cases treated with betamethasone. So that suggests some benefit. But please have a look at the incidence of neonatal hypoglycemia, which was 60% higher following betamethasone. Betamethasone and the effect on neonatal hypoglycemia seems to be more dominant when giving it at almost term gestation than when giving at early gestation. Secondary analysis of this study, published a year ago, showed that the woman-infant pair costs are lower in the betamethasone group as compared to the placebo group. However, we do not have data yet, at least I didn't find them in literature, on 2 years outcome and on a possible differential effect between the gestational age ranges, 34, 35, etc. Since we know that the incidence of RDS is much higher at 34 weeks than at 35, 36 weeks, and then at 36, 37 weeks. So it might be that there is a benefit when giving early, 34, 35 weeks, but with no significant effect later on. We do not know that, nor do we have an idea on the incidence of neonatal hypoglycemia at the different gestational ages. So what should we do? According to neonatologists, a better long-term outcome following this steroid treatment is unlikely, since in late gestation only minor and isolated symptoms may be prevented, whereas at early gestation it's severe symptoms and syndromes, and they mainly determine outcome. And that was also the conclusion by this European consensus guidelines on management of RDS. Also in the United States, there were some doubts. Here, the group of Alan Job, antenatal steroids beyond 34 weeks of gestation. What do we do now? The greatest effect is a reduction of transient tachypnea of the newborn, which is a mostly self-limited condition. This benefit must be weighed against unanticipated outcome, such as neonatal hypoglycemia, and unknowns about long-term neurodevelopment, follow-up, and metabolic risk. In Europe, for the time being, most countries have decided not to give steroids in women with spontaneous labor in between 34 and 37 weeks, and that was also emphasized by Professor Macron when he visited the distinguished President of the United States. Primum non nocere. And finally, what about steroids before a cesarean section after 34 weeks of gestation? Well, there are some data, and the largest one is the EXTIC trial that shows that if you give steroids at term women undergoing an elective cesarean section, then the respiratory morbidity is significantly reduced. Hooray! But at the age of 12 years at follow-up, there were no benefits if you look at outcome. And there was some worrying sign if you look at school performance in the children following betamethasone. If you look at the school performance in the lower quarter of the academic ability, that was significantly higher in the betamethasone group as compared to the control group. So for the time being, my conclusion about should we give steroids in cesarean section after 37 weeks? Well, there are short-term advantages, no long-term benefits, somewhat poorer school performance. So it's better not to give steroids. And I would prefer to do an assessment of fetal lung maturation in amniotic fluid to decide which fetuses really might need corticosteroids. At 34 and 37 weeks is an elective cesarean section. They lack the advantages of the stress of a vaginal trial of labor. So yes, at that age, I would give corticosteroids before an elective cesarean section. But also in this group, better first determine fetal lung maturation. Thank you very much for your attention.
Thank you very much, Jerry, for this very exciting presentation, because as you know very well, practically all the world, they use the corticosteroids very easy, and the majority of the centers are not sensible to the some effects that the corticosteroids can have in the long term. And also the problem of the corticosteroids in the cesarean section. Probably, if the patients deliver by vaginal route, also including in the 34 to 37 weeks of gestations, probably there are not differences between the corticoids and the route of delivery, of the vaginal route of delivery, because during the vaginal route, there are one increase of endogenous corticoids that can mature or prepare the lung of the fetus without any treatment from outside. Thank you. It's a very exciting presentation. And now I want to present, it's a pleasure for me to present Professor Romero. Roberto, it's one of the most important researchers around the world in the perinatology. For me, it's very nice to introduce Roberto because in 2012, he received the award of the honoris causa of my university, and I was I give to him the locutation of his I don't know in English now, las propiedades bonitas que tenías tú, all the best one that he has in his curriculum was introduced by me in the university, and for that reason he received the honoris causa. Roberto, I'm sorry, but my English, as you know, is not so good. And
Thank you, Luis, for that very kind words. I'm very proud of my association with the Universidad Autónoma of Barcelona, and that you introduced me.
Well, now I need to say the title of your presentation. It's the antibiotics to treat intraamniotic infection in preterm labor. Professor Romero has published a lot of papers around the symbiosis of the infection and prematurity. For that reason, it will be a very good pleasure to hear your news about that. Roberto, thank you very much, and I give you the possibility to speak for all the audience.
So, premature labor is one of the most difficult problems in medicine. We diagnose premature labor when patients have contractions, changes in the cervix, and then decidual membrane activation. So it seems like a very simple condition, patients contracting. But this syndrome is due to multiple mechanisms of disease, and we have worked on the role of infection in spontaneous premature labor and delivery. So what I like to do today is to review the importance of this and the role of antibiotics, because things have changed in the last 2 years. 1 of every 3 preterm deliveries come from a mother who has microbial invasion of the amniotic cavity detected by either culture or molecular methods. So it is common because it's roughly 1 of every 3 spontaneous preterm deliveries. What is the origin of microorganisms that are present in the amniotic cavity? Well, performing studies in which we did amniocentesis in patients in premature labor with intact membranes, we identify the organisms using culture, and this is what is called a cultivar, the organisms in the amniotic fluid. Then we examine the 16 RNA gene sequence of these organisms, and next we collected samples from the vagina to ask the question, how many of these organisms that are found in the amniotic fluid are also present in the vagina? So we perform 16S RNA surveys of the vagina, we sequence, and then we compare those in the amniotic fluid and the vagina. And 75% of the organisms cultured from the amniotic fluid are also detected in the vagina. So this is the most recent evidence published last year that supports the concept that infections of the amniotic cavity come from through an ascending infection. Now, the next question is whether infections in the amniotic fluid are causally linked to spontaneous premature labor or delivery, or are just an association. And this is an important question because only if it's causal, then treatment will be of benefit. So these are the criteria proposed by Sir Branford Hill to examine causation in medicine. And these postulates were developed when assessing the relationship between smoking and lung cancer. And they are listed here. The only point that I want to make is that the same criteria are met by infection in the amniotic fluid. If we take animals and we give them microbial products such as endotoxin or bacteria, they go into labor. This is a consistent relationship. We find infections in the mid-trimester are followed by spontaneous onset of labor. The association is strong. There is a dose-response gradient, and human experimentation, which I'm going to discuss today, support that intraamniotic infection can be treated. The same for intraamniotic inflammation, and results in a reduction in the rate of preterm delivery. So the relationship is causal. Now, if infection causes premature labor, can antibiotics prevent premature labor and delivery? Now, this question was first asked, and there was this randomized clinical trial of patients who presented in premature labor. Patients were randomized if they met this criteria: preterm labor less than 34 weeks of gestation, and a phase cervix dilatation between 1 and 5, to erythromycin and placebo. And the conclusions of this trial is that patients who received adjunctive erythromycin had a longer duration of intrauterine stay and a lower rate of preterm delivery than patients who were allocated to placebo. So because of this observation, there were many randomized clinical trials, and I just want to summarize this by showing you a Cochrane library review that antibiotic administration does not reduce the rate of preterm delivery. And this is the reason why clinical guidelines do not recommend the administration of antibiotics. Now, the next question is why antibiotics do not appear to work. And the reason for that is simple. Premature labor is a syndrome of patients who present with spontaneous premature labor and delivery. If you take all comers, the frequency of positive cultures is 10%. If you take those who deliver preterm, the frequency is 22%. So only a fraction of all patients with spontaneous premature delivery will have an intraamniotic infection. But then the next question is, is there any evidence that treatment of intraamniotic infection with the administration of antibiotics can eradicate intraamniotic infection? So the first line of evidence comes from studies we did in women who have a short cervix. These are women who have only a short cervix. We perform amniocentesis in these patients. The rate of intraamniotic infections, 9%. And of those patients, this is what happened. One patient had Fusobacterium in the amniotic fluid. That patient developed clinical chorioamnionitis at upper term delivery. But we have 4 patients who had ureaplasma ureolytic in the amniotic cavity. We gave these mothers azithromycin IV. We repeated the amniocentesis. And when we repeated the amniocentesis after treatment, in 3 or 4 patients, intraamniotic infection was eradicated and the patient delivered at term. So this means several things. First, the rate of bacteria in the amniotic fluid in patients who have a short cervix is 9%, 1 of every 10. Second, infections are subclinical because the only clinical manifestation is a short cervix. Then, if we give antibiotics, we can eradicate in a subset of patients intraamniotic infections. What about the patient who presents with an episode of premature labor with intact membranes? Well, there are several case reports that show that the administration of antibiotics to patients who have a positive culture can eradicate intraamniotic infection in patients with spontaneous premature labor and delivery, and the same can be said of patients with preterm PROM. Now, most of this evidence comes from small series and case reports. So the question that I would like to address today is not whether antibiotics should have been administered to all patients with premature labor, cervical insufficiency, or preterm PROM, but patients in whom we perform an amniocentesis and they have an episode of premature labor and have intraamniotic infection or inflammation, cervical insufficiency, and preterm PROM. And these studies that I'm going to present now have been published in 2019 and 2020. So let's go to the first study in which the effect of antibiotics was examined in a group of patients with premature labor and intact membranes. These were patients with singleton gestation between actually 20 to 34 weeks of gestation who had an episode of premature labor and intact membranes. The patients had an amniocentesis and there was an elevated IL-6 or MMP-8 in the amniotic fluid and the presence of a positive culture. These patients received antibiotics with 3 agents, and the antibiotics were IV ceftriaxone, 1 gram IV every 24 hours, clarithromycin 500 milligrams by mouth every 12 hours, and metronidazole IV. And this combination was chosen. The studies were done at the Seoul National University based on what we had learned about the microbiology of intraamniotic infection. So there were 50 patients who met this criteria. We performed an amniocentesis, and then the team of Dr. Jung observed that of these 50 patients, 21 delivered within 7 days. This is because they have a cytokine storm in the amniotic cavity. There were 29 patients who were undelivered by 7 days, and of those patients, 10 did not have a repeat amniocentesis, and then the remainder, 19 patients, had a follow-up amniocentesis. And we observed is a resolution of intraamniotic infection or intraamniotic inflammation happening in 16 of the 19 cases. And this is, in essence, a resolution of intraamniotic infection or inflammation in 79% of the patients, 15 or 19. And treatment success defined as resolution of intraamniotic infection and or delivery at term occur in 84% of the cases. So this is a case series, it's the largest in the world, that demonstrates that even in patients who had an episode of premature labor and delivery with an elevated IL-6, it is possible to eradicate intraamniotic inflammation and intraamniotic infection. I want to emphasize that most of these patients had intraamniotic inflammation with a negative culture. So antibiotics were effective in eradicating intraamniotic inflammation. So this is the conclusion from this study, that beyond case reports, antibiotics can eradicate both infection and inflammation. Now, the second condition is cervical insufficiency. This is a transabdominal scan, a full bladder. This is the anterior uterine wall. This is a cervix, but the membranes are prolapsed into the vagina. This is a transvaginal scan. And here is how those patients look like. Now, many years ago, we did a study in which patients who were scheduled to undergo cervical seclage, who presented with cervical insufficiency, underwent mid-trimester amniocentesis before the seclage. And 51% of these patients, that means 1 of every 2, had a positive amniotic fluid culture for bacteria. Because the gram stains were negative in several of these patients, we took them to the operating room and had a seclage. The organisms that we found in the vagina, in the amniotic fluid, were those that were found in the vagina. And every time that we place a seclage in patients who had bacteria by culture, these patients lost their pregnancy either because rupture of membranes, clinical chorioamnionitis, or they continued to contract. So the next study, also performed at the Seoul National University by a team led by Dr. Jung, explored the efficacy of antibiotic administration in patients who have acute cervical insufficiency. These were singleton gestations, patients who presented with painless cervical dilatation between 16 and 27 weeks of gestation. Patients had intact membranes and did not have uterine contractions. There was a confirmed intraamniotic infection or inflammation by amniocentesis, and the same combination of antimicrobial agents were used. And there was a follow-up amniocentesis to monitor response to therapy. The doses of antibiotics are the ones identical to those in patients with premature labor and intact membranes. Now, there were 22 patients who presented with acute cervical insufficiency, had intraamniotic infection or inflammation, treated with antibiotics. Of those patients, 6 delivered within 1 week, again for the same reason. They had a cytokine storm and they proceeded to have a preterm delivery. There were 16 patients who didn't deliver within 1 week, and of those patients, an amniocentesis was repeated in 12 patients. In 9 patients, there was resolution of intraamniotic infection or inflammation, and the conclusion, of course, of this study is that treatment success in patients who appear hopeless because the cervix was dilated or the membranes were bulging was successful in 59% of the cases, 13 or 22. So the conclusion of this second study is that antibiotic administration, even in patients who have a dilated cervix, who have prolapse of the membranes, can be successful in eradicating infection or inflammation. What about the third condition, pre-labor premature rupture of membranes? Here, I want to remind you that 1 over every 3 patients who is admitted with the diagnosis of preterm PROM will have bacteria in the amniotic fluid by culture. And when the patients go into labor, so if we repeat the amniocentesis when the patients begin preterm labor, 75% will have microorganisms by culture. If we use molecular techniques, the frequency will be higher. Now here, antibiotics do prolong the latency period, and randomized clinical trials in which patients with preterm PROM have been allocated to no treatment or placebo or antibiotics suggest that there is prolongation of pregnancy and improvement in neonatal outcome, as illustrated in every red box in this slide. So that is the reason why antibiotics are used in clinical management. Now, the next question is, can antibiotics treat intraamniotic infection or inflammation in preterm PROM? So a similar study performed at the Seoul National University, singleton gestations, patients, this was a retrospective cohort study with a historical control group. All patients had preterm PROM at less than 34 weeks of gestation. The patients underwent 1 amniocentesis, and then the amniocentesis was repeated within 15 days to assess the microbial status of the amniotic cavity. Intraamniotic inflammation was defined as an elevated MMPA, and intraamniotic infection has a positive amniotic fluid culture. Between 1993 and 2003, patients were treated with ampicillin, IV, or cephalosporin. The second regimen between 2003 and 2015 was a combination of the 3 antibiotics I mentioned before. And if we look at what happened, or the conversion of preterm prom without intraamniotic infection or inflammation according to antibiotic regime, these are 27 patients who did not have infection or inflammation. They were given ampicillin or cephalosporin, and of those, 10 evolved to have, over time, infection or inflammation. In the group of patients, there were 12 patients who were treated with the triple combination of antibiotics, and in this case, only 2 developed infection and inflammation. So with a historical control group, the rate of conversion with a new antimicrobial agent was lower than before, although not statistically significant. Now, the next question is, what happened with patients who have intraamniotic infection or inflammation? These were 14 patients who have inflammation in red or bacteria in the amniotic cavity. They were given ampicillin or cephalosporin in the first part of the study, and in no case there was reduction in the rate of inflammation or eradication of intraamniotic infection. In contrast, with the new combination of antibiotics, 36 patients received this treatment, and in 12 cases, or 33% of the cases, intraamniotic inflammation was resolved, or the infection also resolved. So this is statistically significant, indicating with a historical control group, with all the limitations that that has, there is a resolution of infection or inflammation. If we look at the interval to delivery, this is the historical control group in blue, ampicillin or cephalosporin. The group that had the triple antibiotic administration had a lower latency, and this in patients with the new antimicrobial combination, and this is a greater detail, also a significant increase in the latency period. Now, perhaps the most important finding is that the rate of phoenicitis in patients who were treated with preterm prom with ampicillin and cephalosporin was 42% in patients treated with ampicillin and cephalosporin, but in patients who were treated with the antimicrobial agent, the frequency was 14%, so there was a reduction in the rate of phoenicitis. This is important because this represents a fetal inflammatory response, and there is no way to bias this because this depends on the examination of the placenta. Now, I would like to close by showing some fascinating studies that were conducted at the Czech Republic by Marion Kacerowski and Ivana Musilova and the team at the Czech Republic. This paper was published this year in the American Journal of Obstetrics and Gynecology and represents demonstration that antibiotic administration reduces the rate of intraamniotic inflammation and infection in preterm labor in preterm prom. So this study included singleton gestations who were admitted with preterm prom between 24 and 33 weeks of gestation. All patients had an amniocentesis on admission. The investigators performed a bedside IL-6 test, lateral flow, that is available in Europe. There was a PCR performed for the detection of ureaplasma, mycoplasmas, and 16S, and then amniotic fluid cultures were performed. Patients were divided into 2 groups. The ones who had an elevated IL-6 were given clarithromycin IV as the only antibiotic, IV 500 milligrams every 12 hours for 1 week. And the patients who had without intraamniotic inflammation, who had a low interleukin-6, were given penicillin 5 million international units, followed by 2.5 for 5 days. Now, patients who were allergic to penicillin were given clindamycin every 8 hours for 900 milligrams for 1 week. So what happened here? Of the patients, there were 40 patients who underwent repeat amniocentesis. There were 26 who did not have intraamniotic inflammation, depicted in blue here. There were 14 patients who had intraamniotic inflammation or infection. Half had intraamniotic infection with more microorganisms. The other ones have what is sterile intraamniotic inflammation. They were given clarithromycin. And the results of this study, in essence, show that the administration of clarithromycin reduce the intensity of the inflammatory response in patients who have intraamniotic infection. So they have microorganisms in the amniotic cavity. This is the initial IL-6. This is the follow-up IL-6 when they were treated with clarithromycin. If patients had ureoplasma in the amniotic fluid, there was a reduction in the microbial load estimated with the gene copy numbers, and clarithromycin also reduced the intraamniotic inflammatory response in patients who have intraamniotic inflammation, even if they didn't have bacteria. Now, in patients who did not have inflammation in the amniotic cavity, they were given penicillin and clindamycin because this is the standard of practice. You can see that there is no response or reduction in the inflammatory response. So the conclusion from this study is that antibiotic administration attenuates the intraamniotic inflammatory response in patients with preterm PROM. Now, what are the conclusions from this set of observations? That antibiotics can eradicate intraamniotic infection and inflammation in patients with preterm labor and intact membranes, preterm PROM, and cervical insufficiency. And this data goes hand in hand with the concepts that were presented by Teresa Cobo earlier in this session. If we give antibiotics to all patients, patients do not benefit. But if we select those who have intraamniotic infection or who have intraamniotic inflammation, even with microorganisms, the evidence that we have today is that this intervention can result in eradication of the inflammatory process and prolongation of gestation to term. Now, those of you who may be wondering, why is it that we haven't performed a randomized clinical trial? Well, a randomized clinical trial is very difficult to do because it will require that we do an amniocentesis and then do not act on the results of this test. And this cannot be justified in the context of clinical care. Now, to close, a new and important development, and this observation was just reported this year, is a new point-of-care test to diagnose and monitor intraamniotic inflammation in patients with preterm PROM with transcervical collected fluid. This is a cervical collector developed by Dr. Jung at the Seoul National University, where this balloon is placed against the cervix and then fluid can be collected through this catheter. And the way this works is, is described, and I'm going to show you a picture in a moment. And a point-of-care test has been developed to rapidly assess the presence of an elevated IL-6 in the amniotic fluid. So the way this works is this was tested in patients who have preterm PROM at less than 35 weeks of gestation, singleton gestations, and amniotic fluid was collected using a cervical amniotic fluid collector, and patients had an amniocentesis. So an amniocentesis was performed, the catheter was placed against the cervix, and fluid was collected, and IL-6 was measured with ELISA and also was measured with the point-of-care test. And in essence, the patients who have intraamniotic inflammation determined by amniocentesis also had an elevated IL-6 in cervical amniotic fluid. And this approach to assess IL-8 in amniotic fluid collected to a cervical catheter had excellent sensitivity and specificity and good and predictive values for the detection of intraamniotic inflammation in the amniotic fluid. So the conclusions from this study is that there is an approach to assess the state of inflammation of the amniotic cavity of patients who have preterm PROM. So these are developments that have occurred in the last 2 years, and I think that they open the door for our exploring, assessing the patients who have cervical insufficiency, preterm labor, and preterm PROM to see if they have intraamniotic inflammation, and then to try to target that inflammatory or infectious process with aggressive antimicrobial therapy. Thank you very much for your attention.
Thank you very much, Roberto, for your very, very exciting and very nice presentation. I see that we have a problem now because, as you see, your watch, it's the 3 hours. It's the hour 3 after in the afternoon, and at that moment, you are the chair of another session
Yeah.
It's a huge
Yeah,
emergency.
sorry to interrupt. This is Fabio speaking. Professor Di Renzo already take over the chairmanship in the other session. So if you want to have a few minutes of discussion, please
okay.
go ahead.
Luis, why don't you take some questions?
Okay. Well, I will give you one personal question. You explained during a lot of years that there are different categories of infections. One is amniotic fluid infection, one other one is inflammation, and the third one is the inflammatory syndrome of the fetus. Well, with the cultures, we analyze only amniotic fluid, but we cannot know what happens in the fetuses.
Sure.
You can include other parameters in order to decide if there are other effects, not only in the amnios, also in the fetuses, like in brain or like in myocardial or like in lung. You can answer that.
When we assess amniotic fluid and amniotic fluid white blood cell count, most of the white blood cells that are in the amniotic fluid come from the human fetus. So an elevated MMPA and an elevated amniotic fluid white blood cell count is a surrogate, is an indirect marker of fetal systemic inflammation. But there is not a good way today to assess whether there is systemic fetal inflammation before birth. But the data that I show in preterm prom gives us a hint that if we eradicate intraamniotic inflammation and infection, that may reduce the rate of fetal systemic inflammation. But I don't want to, I want to, the purpose of my presentation is to tell you the standard practice is not to give antibiotics to patients who have premature labor and intact membranes, and we don't give them to patients who have cervical insufficiency. And the message that I have is that if we identify infection and inflammation, which today requires an amniocentesis in those patients, it is possible to eradicate this infection in roughly between 60 and 70%. And that information we didn't have before. So that is new information. So what that means, in all patients who have premature labor, there is no indication for antibiotics or in patients who have cervical insufficiency. But in those who have intraamniotic infection or inflammation, that maneuver can reduce the rate of the pathologic process and is associated with preterm delivery. That is the main message that I wanted to convey. And I believe this is consistent with the data that Teresa presented earlier, about the prevalence of infection, the issue that is more frequent in early gestational age, and other concepts. Luis, I would like to see if we can involve the other members of the group. And I wonder if we have questions for Eduardo, Teresa, Jerry, and Eduardo. Do you have a question for Teresa?
There are, for Teresa, there are some questions that the audience sent us.
We have a large number of questions. Teresa, I'm going to just ask you a question that has been asked by those. First of all, you have a very high rate of acceptance of amniocentesis. Do you have can you share with us the frequency with which rupture of membranes occurs in patients who have preterm labor and intact membranes? Because one of the risks when we have intraamniotic infection is that the membranes rupture more frequently in the patients who have positive culture than negative culture. And as you correctly pointed out, people are apprehensive about amniocentesis. So what is the frequency with which you perform an amnio and then the patient ruptures the membranes within, let's say, a few days after the procedure?
Mm-hmm. The frequency is really, really rare. So the amniocentesis is performed by our people in training, by the residents, when a woman comes to the hospital and before administration of tocolysis. So I cannot give you the number, but this is really, really low. So it's a very secure procedure because it's performed a third trimester. The uterus is very big and there are intermembranes. And I tell you that it's not done by a senior. specialist. It's performed by a resident in training. So it's a safe procedure.
Amniocentesis is easy to perform because there is a lot of fluid, and also the rate of complications
It's very, very rare.
But people will always be concerned that if there is rupture membranes, can physicians be held liable because they perform an amniocentesis? This is what people are concerned with. The second question for you, and then we'll go back to Edward, is you have in your hospital a rapid IL-6 and a PCR for bacteria. Is that correct? How long does it take for you to get results for IL-6 and for the PCR for 16S?
The 16S RNA, it's performing research. So we don't use it in our clinical setting. We use it only for research. But interleukin-6, the result is in the following 40 minutes.
Okay.
So it's really a rapid result.
Great. Thank you. Edward, are you with us here?
Edward is not here because he had another meeting at 3 p.m. I'm sorry.
He's in the same situation as I am. May I ask Eduardo? I noticed, and I think that Jerry sort of hinted at this, and Luis, there are two questions for you. The first one is, in patients who have a history of preterm birth, but do not have a short cervix, what is your recommendation about the management of these patients? In the US, people have offered 17-OHPC, 17-alpha-hydroxyprogesterone caproate. Can you tell us 17-alpha-hydroxy caproate, yes or no? Your music.
Great. Yeah. Unfortunately, we have now data that demonstrate that 17-hydroxyprogesterone should not be used for patients with prior history of preterm birth. Actually, we have an advice from FDA to avoid use it. So I'm quite confident if I have a patient with prior history of preterm birth and the cervix is long, so we just follow this patient and there is no need to do anything else. So I'm confident, and I'm not going to use 17P for this case.
Can I just clarify? There is a large randomized international trial in which women with a history of preterm birth were randomized to 17-alpha-hydroxyprogesterone caproate or placebo, which is a replication of the NICE trial. And this study did not show any evidence of efficacy either in the US or in the rest of the world. So the evidence that was once invoked to use 17-OHPC does not seem to stand.
There is a, sorry. No, sorry, continue.
Sure. So I believe that we can make progress because probably those regular injections are not necessary. I think that Luis to this.
I have one question.
Yes.
I have one question for Eduardo, coming from the audience, that say that in cases of patients treated by progesterone, what is the marker or what is the parameter that you use for control the evolution of this pregnancy? I suppose that the audience, these people want to analyze what is the role of the cervical length in these cases that you are treated by progesterone during the rest of the pregnancy that you are treated the patient.
So sorry, Luis, I couldn't get the question. If the
can I just? The question is, if you are giving progesterone, how should the patient be monitored with serious cervical length? And what do we do if the cervix shows?
Okay, perfect. So if the patient had a prior history of preterm birth, less than 34 weeks, so the advice is to check the cervix from 14, 16 weeks to 22, 24 weeks. And there are some protocols that says that you could use vaginal progesterone. So if the cervix get short, even with progesterone, we could try cerclage before 24 weeks. So if the cervix is short and there is no another risk factor, you're going to give just progesterone. And I believe that in the management, we have to bring the patient close to you, follow the cervix, and if the cervix is going shorter and shorter, unfortunately, so far, there is nothing to be done unless to try to find infection or something else that you can treat and decrease. But taking account RCT, there is nothing to do in patients with short cervix, and you are giving progesterone, and the cervix is shortened and shortened, and the patient there is no another risk factor.
So can I say, once we give vaginal progesterone as a first line treatment, we perform cervical ultrasound, cervical lens every 2 weeks, and if the cervix shortened, and we will define that as a cervix that is 10 millimeters, those patients become eligible for cerclage. And there is a report from the United States that if that is the case, cerclage reduces the rate of preterm delivery by approximately 80%. It's the only data available in the literature today. Let me ask a question to Jerry. Jerry, if I look at the last bottom line slide, there's no indication for the use of steroids in patients who are going to deliver a term, even by elective section. And in patients who are in the late preterm window, can you just revise your analysis of the risk benefit? So, for example, I had a patient that delivered yesterday at 36 weeks of gestation electively because of some medical complication. What would be, if the patient is not in labor, is going to undergo an elective section, and then if the patient presents in spontaneous premature labor, those are the two common conditions. What is your bottom line recommendation?
Thank you very much, Romero. There was also a question from the audience. Similarly, monochorionic diamniotic twins at 36 weeks of gestation, cesarean section, what would you do? Before 37 weeks, I would give corticosteroids, but if I can, and in my hospital we can, I first would do measurement of fetal lung maturation, laminar bodies or LS ratio, and then you will see that in the majority of cases, you do not need it. If it is twins, do the amnio in the top one, because that's most likely the one that has less mature ones than the other one. So that about, let's say, 36, 37 weeks of gestation. If you allow me, there were a few questions, and the question and answer session, do you give corticosteroids before 24 weeks of gestation? Yes, if you treat neonates at that gestational age, 22, 23, 24 weeks, steroids work. No randomized studies, but observational studies that are very convincing. They do not really reduce RDS, but mortality, probably because they prevent neonatal hypotension. Betamethasone or dexamethasone, only indirect comparison, betamethasone might be a bit better, but it also has more side effects. Reduction of fetal movements, reduction of fetal heart rate variation is restricted to betamethasone. What about diabetes? Well, we know that if you give corticosteroids in a woman with diabetes, that may result in severe hyperglycemia. So if you want to give it, first consult your internist, but also in these cases, I would first measure lung maturation and then decide whether or not to give it. If we induce with diabetes at 36 weeks, we don't give steroids because induction of labor and labor itself may enhance lung maturation. But in case of cesarean section, that is different. What are the side effects of one course of steroids on later life? As I indicated, there are not many. Maybe there is some insulin resistance. For the rest, we do not know yet. So that is rather reassuring. But if you give steroids more or less close to term, then you see neonatal hypoglycemia. And if untreated, that may definitely have impact on development of the infant later in life. Those were the questions that I found on the question side. Thank you.
Thank you. Thank you very much.
Louis,
yeah.
do you want to make any comments to end the session? Or any other?
I am very happy to have the chair of this session with you. I want to congratulate all the speakers because the lecture was very nice, very clinical level, very research level, but for the clinicians that are in the audience also was very useful because all of you give very clear messages, very clear take-home messages that can be used at home. There are many questions that repeat the same question, and Jerry answered the majority too, but there are others, for instance, that are asking for the role of fibronectin in all these matters, because probably in some hospitals or in some areas they have fibronectin and not have other markers. But well, I think that you give the majority of the solutions for the problems that our audience has presented now today in this very nice and very exciting session, that it's the prematurity and his darks, and also his areas that we know. For that reason, I will finish saying thank you, all of you, for coming, and I invited to you for the next session that will be acute emergencies in labor with Roberto Romero will be the chair. Thank you very much, all of you. And I'm sorry for my English, but I give all the English that I have.
Louis, thank you very much. It was a real pleasure.
Okay.
Let's move on to the next session. Thank you.
Louis, thank you. Nice to see you again. Bye.
Bye. Bye.
Let's
Bye.
go for the next.
Bye. Bye.
When CAPS is suspected. Probably it would be beneficial for all women with severe preeclampsia to be routinely tested for the presence of antiphospholipid antibodies. Why do obstetricians need this? It's not in guidelines, but maybe because all emergent conditions occur suddenly and there is no time for serological research method to correctly diagnose and understand the pathogenesis of this situation. Preeclampsia, septic shock, thrombosis, and other clinical critical conditions are practically different from the point of view of pathogenesis, prognosis, and outcome, and require different treatment. But the knowledge of antiphospholipid antibody presence in these women may change the therapy. It would allow to prescribe adequate therapy with the use of heparins, plasmapheresis, and maybe avoid unnecessary, ineffective interventions. At the end of my speech, I would like to say a few words about Professor Ronald Ascherson, who first described the main manifestation of the new syndrome. And since that time, this devastating variant of antiphospholipid syndrome has been called Ascherson syndrome. He was an invited speaker and visited professor of at most leading universities and hospitals in the world. And in 2007, he was invited by my teacher, Professor Alexander Makatsaria, to Moscow, and all members of our department came to see him. Unfortunately, Professor Ronald Ascherson passed away in 2008 in Johannesburg, South Africa, but he was outstanding and caring physician, and this syndrome has his name, and we had the great fortune to know him. Thank you very much for your attention.
Thank you very much, Jamila, for this interesting and important talk. We could encourage participants to write some questions in the questions and answer tool here in the bottom. So we have 5 minutes for some 2 or 3 questions to answer.
Yeah, I would like to add one important information. Professor Macazziari and his group is probably one of the leaders in all Russia and Europe on coagulopathies and pregnancy. And he's just released, I think 1 year ago, a very nice review in the Journal Maternal-Fetal Neonatal Medicine on the catastrophic antiphospholipid syndrome connected to pregnancy. So if you want to read something that is exhaustive on this, comprising treatment and so on, just go to the journal, to the Black Journal, and you can download the very nice review that the group has done. So I welcome everyone to read it, because it's a very complicated issue, as you heard, and it's not easy to understand how this develops from a very mild beginning and then can be something that in few days became really catastrophic. I don't think that we have a question for this specific case, or you have some comments, Daniela?
Oh, no, I would like to ask something to Jamila, because as you know, like COVID-19 disease is a really prothrombotic disease. So have you seen an increase in the incidence in antiphospholipid syndrome during the last pandemic?
Thank you for the question. We are working in this field, and we have a lot of patients, COVID patients, and we are busy with them, not only pregnant and women, but a lot of, and we see the increase of antiphospholipid antibodies in these patients.
Okay.
Yes.
I think Professor Romero is online now to co-chair. Correct, Roberto? Are you reading? Because you finished the other session, Alexander. I think Roberto is connected, but I don't know if he's still online. But in no?
Yes, of course, yes.
But in oh, Alexander.
Hello, Giancarlo. Hello, Giancarlo. And Roberto?
He's online. He's online. I see that he's connected, but I don't see him.
Yes.
He's here.
Thank you very much for inviting in participation in this conference. It's a great honor for us, and we are ready to cooperate with you always.
Okay, good. I think that we can move, Daniela, because we need to speak about the other cases. Thank you so much, Alexander, Jamila, Victoria, and all the group. Fantastic job.
Thank you. Thank you very much. So our next presenter is Professor Sergei Barinov, also from Russia. He is the professor and chairman of the Department of OBGYN at Omsk State Medical Academy in Russia. His main interests are organ preservation, surgery in placenta accreta, spectrum disorders, early preterm birth prevention in women with high risk for spontaneous preterm birth and placenta previa, and prevention of purulent septic complications after C-section. So today he will be presenting preserving surgeries in patients with placenta accreta spectrum. Thank you very much.
The problem of obstetrical bleeding remains relevant both in the Russian Federation and around the world, as it is often accompanied by the loss of a reproductive organ. The Omsk region is the 28th largest and the 23rd most populated region of the 90 Russian regions. The Omsk region is located in the southwest of Siberia. It occupies a territory of 141,000 square kilometers. The population of the Omsk region is 1,960,000 people. The Omsk Regional Perinatal Center has around 4,000 deliveries per year. Most frequently, deliveries with major bleeding are accompanied by hysterectomy, placental presentation, placental hernias, and placental rotation. Nowadays, women have a hope to preserve an organ. This has become possible with the help of mitroplasty, a surgery involving simultaneous resection of a uterine wall penetrated into by placenta previa accreta. In the Russian Federation, it was academician Mark Arkadyevich Kotzer, who became a pioneer in such organ-preserving surgeries. The mind behind such surgeries is Viktor Yevseyevich Radzinsky, the founding father of Zhukovsky tamponade implementation in patients with obstetrical bleeding. The bleeding rate in the regional perinatal center of Omsk remains the same and equals 2.9 to 1.2%. Non-major obstetrical bleeding prevails by frequency. However, cases of major bleeding amount to almost 10%. Most of the time, such bleeding is dangerous. It should be treated as a massive blood loss because a minor hidden blood loss can lead to a tragedy. In September 2012, WHO experts developed recommendations for the implementation of intrauterine balloon tamponade in patients irresponsive to uterotonic drugs. In our clinic, uterine and vaginal module has been widely applicable since 2012. Since 2014, we have been using the Zhukovsky vaginal catheter. We participated in the development of this module. And as you can see, every year administration frequency of balloon tamponade goes up. This technique is mostly used for cesarean sections, which account for 70% of cases, while postpartum bleeding accounts for 29% of cases. According to our data, placenta previa and multiple pregnancies are the leading causes for bleeding occurring during cesarean section. These are so-called lower segment hemorrhages, in which conventional methods of bleeding arrest are not efficient. We have developed a combined treatment for postpartum bleeding. First, it comprises surgical hemostasis, ligation of the descending branch of the uterine artery, application of a utero-supraplacental assembly suture, correction of coagulation disorders by the means of thromboelastography, and finally, a balloon tamponade is inserted to stop the bleeding. It is the first time that we show a picture demonstrating a mechanism of how vaginal and uterine modules of a double balloon tamponade work. It is here that the effect of a balloon tamponade on the vascular plexus is depicted. The vaginal module tampons arteria vaginalis and the sacral artery. The uterine balloon produces a mechanical effect on the placental bed. In this case, both balloons exert a double effect on the uterine wall, in particular on the parametrium. This is the mechanism for hemostasis. The figure also shows the areas for uterine artery ligation, in cases with both upper and lower levels of placental invasion. Currently, the incidence of placenta previa and the number of cases of abnormal placentation has increased. If you look at the slide, we had 99 cases of placenta previa over the past year. 36 of them, or 33%, were cases of placental penetration, while placental hernias accounted for 14 cases, the number of which has increased 2 times over the past 2 years. In the Russian Federation, ultrasound is considered to be a screening method for diagnosis of placental ingrowth, while MRI is perceived to be an additional method. At the same time, MRI is used abroad in cases with placenta previa and for the diagnosis of placental ingrowth. For surgical treatment, the following scheme of balloon tamponade is used. When placenta is presented, the vaginal module is installed first, then an incision is made on the uterus, the fetus is extracted, and then the vaginal module is filled with a saline solution in the volume of 180 milliliters. After that, surgical hemostasis is performed alongside the pre-installed vaginal module. When hemostasis is completed, the wound is sutured. During the cesarean section, a uterine balloon is passed through the incision into the axial tube of the vaginal module. Following wound suturing, the uterine module is filled in and thus a double balloon tamponade is obtained. We have developed a special method for placenta previa. If the penetrated area does not exceed 5 cm in width and the depth of invasion is limited to 1/3, we perform excision of the part invaded into by placenta accreta and hemostasis simultaneously. If the width exceeds 5 cm and the depth of invasion equals to 2/3, we perform resection of the uterine wall penetrated into by placenta accreta. Here, the invaded area along the posterior wall of the uterus is quite large. You can see resection of the uterine wall. The most dangerous defect in terms of surgical tactics and bleeding is a uteroplacental aneurysm or hernia. Major bleeding can occur because of the vascular loci in the placental area. In such a situation, it will be difficult to move away from the bladder wall. Here you can see how to separate the bladder and notice the accentuated vascular pattern that extends to the cervix. In this situation, difficulties arise because major bleeding might occur if we touch these vessels. Now we will show you a case of a woman at 21-week gestation with a dead fetus, complete placental presentation, and a diagnosed placental aneurysm. The woman has also a history of 2 cesarean sections.
18 months later, the patient with full-term pregnancy is readmitted to the perinatal center again. The vaginal module is installed prior to the surgery. During the laparotomy, an incompetent uterine scar is discovered. The fetus with a weight of 3,900 grams is extracted in an intact amniotic sac. Uterine vessel ligation is performed prior to placental separation. Placenta accreta is detected on the left lateral wall. The length of the invaded area exceeds 10 centimeters. Therefore, the invaded uterine wall is resected. An assembly suture is applied below the level of placental invasion. At the same time, an accentuated vascular pattern is detected on the posterior uterine wall in the area of placental invasion. An oblique incision is performed on the lower edge of the penetrated area. After that, an incision along the upper edge is made and part of the penetrated area is resected along with the uterine wall. Here we can see placenta invading into the uterine wall and its resection. The key point of this surgery is to correctly oppose tissues with the help of separate figure-of-8 sutures. We can also see that there is no bleeding occurring. During the investigation of the anterior uterine wall, we notice an incompetent scar in the area of the lower segment. In such a situation, we often face a high risk during its separation from the bladder wall. We carefully cut off a leaf of the broad ligament of the uterus. After that, we approach the lower segment of the uterus and separate the amniotic sac from the bladder and the uterine wall. This is done very carefully so as to avoid any contact. To reduce blood loss, an assembly suture is applied, and after that, the anterior uterine wall is resected. The incompetent scar is removed. We can see that there is no bleeding due to the pre-installed vaginal balloon. However, because of the high risk of post-operative hemorrhage, uterine catheter is installed. Simultaneously, we face certain difficulties as it is necessary to get right into the axial tube. Uterine catheter is installed and the rest of the uterine wall wound is closed with the help of figure-of-8 sutures. When the wound is sutured, an adhesion barrier is installed along the posterior wall of the uterus. It has a net shape. The uterine wall is sutured with the help of separate sutures. An adhesion barrier is installed along the anterior wall. The uterine catheter is installed in the uterine cavity and left filled in for from 8 to 14 hours.
18 months later, the woman is admitted to hospital with a full-term pregnancy of 37 weeks. We've made a picture of the uterine scar and its condition after the meteroplasty. It is a competent scar on the uterus. We performed a routine cesarean section, but again, this operation was performed with a double balloon tamponade. On day 7, the patient was discharged. Here you can see the scar on the uterus, and there are still vascular loci. 18 months later, the woman is readmitted to hospital with a full-term pregnancy of 40 weeks.
18 months later, the patient is readmitted to hospital to undergo a C-section. During the first stage of the surgery, a vaginal module is installed. Following that, laparotomy and C-section are performed. A fetus with a weight of 3,900 grams is extracted in an intact amniotic sac. After that, the umbilical cord is cut and we proceed to bilateral uterine vessel ligation, while placenta remains unseparated. As we examine the state of the placenta, we detect an area of placental invasion into the posterior uterine wall closer to the left side. The area exceeds 10 centimeters, and as we try to separate it, major bleeding occurs. Due to this fact, the patient is diagnosed with placenta accreta, and resection of the posterior uterine wall with penetrating placenta is performed. First of all, an assembly suture is applied so as to reduce intraoperative bleeding and to ensure hemostasis in the area of the operative wound. A linear incision along the bottom line of the penetrated area is made on the uterus. After that, we make an incision along the upper edge of the invaded area on the uterine wall, and following that, edges of the wound are opposed and the penetrated area of the uterine wall is resected. You can see this on the slide. Next, we proceed to wound closure. First of all, we oppose corners of the wound with the help of an assembly suture. We can see that due to the correctly installed vaginal module and uterine vessel ligation, bleeding is prevented, and as the result, corners of the wound can be correctly opposed. After examination of the anterior uterine wall, we detect an incompetent scar. Therefore, plastic surgery of the anterior uterine wall is performed. For this purpose, we pull up the broad uterine ligament and split the leaf of the parietal peritoneum. The bladder is separated from the uterine wall with due carefulness because of the accentuated vessel pattern. To avoid major bleeding from the intraoperative wound, an assembly suture is applied below the area of uterine plastic surgery. After that, the scar is resected and we proceed to plastic surgery of the uterine wall. Once again, an assembly suture is applied onto the uterine wound so as to correctly oppose its corners and to avoid bleeding. This manipulation is performed on both sides. Then, an assembly suture is applied on the opposed corners bilaterally, which allows us to reduce the amount of blood lost. We can see that there is practically no bleeding due to the pre-installed vaginal module, which helps us to correctly oppose the edges of the wound on the anterior uterine wall. The wound is closed with the help of separate figure-of-8 sutures. Due to the high risk of postoperative blood loss, uterine catheter is installed through the axial tube into the uterine cavity. There are certain difficulties arising during the installation of the uterine module, as it is of crucial importance to get into the axial tube correctly. As soon as the uterine balloon is installed into the wound, it is fully sutured with the help of separate figure-of-8 sutures. To avoid adhesion process, after resection of the posterior uterine wall, a net-shaped adhesion barrier is installed. After that, we finally oppose edges, close the wound on the anterior wall of the uterus, and form the lower segment when the wound is closed. To avoid adhesion process in the bladder and the anterior wall of the uterus, an adhesion barrier is administered. Thank you for your attention.
Here you can see implementation of Zhukovsky's balloon tamponade. This is how in 2014 we started to introduce the use of the vaginal module. The introduction of this method has led to a sharp decrease in the number of hysterectomies, despite the increase in the number of complicated surgeries. Most often, we performed a hysterectomy with placenta penetrated into large vessels, parametria, the infundibular pelvic ligament, and the cervix. Here you see the placenta. In such a situation, we cannot handle it yet. Earlier, we talked about penetration into the uterine vessels here, and now we have performed 4 surgeries where uterine vessels have been excised, and after that we moved to the posterior wall and performed an organ-preserving operation. Therefore, in such a situation, a uterine balloon is needed so that there would be no bleeding in the post-operative period. On the volume of blood loss, we see a 3-fold reduction in blood loss. The total number of uterine extirpations has decreased by a factor of 10 since the beginning of the method in 2014 to the present day. A global study is currently being conducted in 9 clinics around the world. We were invited to predict the risk of placental ingrowth, and we were invited to participate in stage 2 to check the data and its implementation, in particular the use of prognostic scales. This slide shows the result of a bicentral controlled study carried out jointly with the Yakut Perinatal Center, involving 385 cases of placenta previa, 117 of which were cases of placenta accreta. In the ROC analysis, the most specific indicators included a large number of birth cases and presence of more than 2 uterine scars. Therefore, predictors for fused placenta currently embrace 4 indicators: 2 or more deliveries, a scar on the uterus, and anemia. The most accurate predictive model is still based on the presence of 2 or more uterine scars. In 81.4% of placenta previa, placental ingrowth can be predicted. In winter, temperatures vary from -35 degrees to -40 degrees Celsius. In summer, from +30 to +35 degrees Celsius. Choose your time of the year to visit us. Thank you for your attention.
Thank you very much, Professor Sergey and colleagues. It was a fantastic presentation. We have some questions, and also, Jamila, there's a question for you, if you would like to answer directly in the writing. So for Professor Sergey, they were asking what's the difference on maternal outcome between this balloon and Bakri balloon. You can see also the question.
Ну, во-первых, мы принимаем двухбаллонную систему. Операция начинается на вагинальный, потом только подключается маточный баллон. А здесь баллон Бактрин не обладает плотным.
First of all, we use double balloon system in Russia. So, the second, we didn't use any Bakri in Russia. So we couldn't have any comparison, compared to Bakri balloon. So that's why we can talk about only Zhukovsky balloon, double balloon system.
Okay, thank you. And there's another comment saying, sorry, this complicated surgery maybe put the patient at risk. What do you think?
Это операция достаточно сложна, для не стоит такого риска делать.
Здесь хирургический риск высокий, но с улучшением хирургической техники и применением двухбаллонной системы риски снижаются.
Happily, we have a very unique technique in order to decrease the risk for patients. And we have around 7 years experience, which shows us that the risk is minimal. And so the second things, and we choose the patients for hysterectomy in order to decrease risk of patients. So this is our experience.
Okay, thank you very much for you all. I think we can move on to the next presenter, who is, unless someone of the speakers wants to say something else. Our next presenter is
Daniela. Daniela, one
yes.
moment.
Yes.
Роберто и
Roberto.
Спасибо за приглашение для участия в этой конференции, показать нашу работу.
Dear Roberta, dear Giancarlo, thank you very much for giving me a chance to present our experience on this big conference. Thank you very much.
Great, excellent. Sergey, thank you. Our next speaker is Professor Ofer Erez from the Ben Gurion University Soroka Medical Center in Israel. And Ofer has made many contributions to the study of disseminated intravascular coagulation. And he's going to tell us about DIC in pregnancy, the labor and delivery unit. Ofer. Welcome.
Thank you very much, Dr. Romero and Dr. Vasquez. And I'm very happy and proud to present in the birth meeting. Seems like a very good venue to do our work. And I will talk about DIC in pregnancy. I would like to start with the case of a 33-year-old woman of G4P3, 34 weeks of gestation, who was admitted to labor and delivery with vaginal bleeding. Now, when we look at her at admission, she had mild to moderate vaginal bleeding with blood clots, a blood pressure of 104, elevated blood pressure and higher heart rate, proteinuria, elevated liver function enzyme and LDH, and low hemoglobin and platelets count. And her fetal status, fetal heart rate tracing was with contraction and a negative CST, and the ultrasound looked this way, and it seemed like they have a retroplacental clot. So the working diagnosis was whether she had a HELLP syndrome, abruption, or both, which seemed the right space. And because she was bleeding, this was her coagulation profile. Fibrinogen 250 milligram per deciliter or 2.5 gram per liter. A PT, which is a bit longer than the control, 12.1 versus 11, which is still within normal range. And PTT within about 1 second longer than the control, but it's still within the normal range as we look at that as clinicians. Now, does the patient has a coagulopathy? This is a question that comes up when she presents that way and we have abruption and HELLP syndrome. And if she has a coagulopathy, is it DIC? So when we look at coagulopathy versus HELLP syndrome, we see that in both syndromes, or both cases, we have low platelets, while those with HELLP syndrome have elevated liver function tests and proteinuria. Those who have a coagulopathy have elevated D-dimers, low fibrinogen, and prolonged PT or PTT. And our patient seems to have both of them. So does she have DIC? And how can we diagnose DIC during pregnancy? In the non-pregnant state, there were several suggestions for a DIC scoring systems, all of them conducted on 4 parameters: platelet count, prothrombin time, fibrinogen, and fibrin split products. Now, in the non-pregnant state, these scores had very good predictive value on the outcome of patients and when they're admitted to intensive care unit and their mortality. However, when you apply them to pregnancy, because all the factors changes during gestation, they were inaccurate and ineffective. So we have developed a DIC score for pregnant women, and it was based on our population in Soroka Medical Center, and we could identify actually with very high degree of precision patients who have DIC using only 3 parameters: the PT difference, the platelet count, and the fibrinogen. PT difference is the difference between the patient and the control. What is the difference between the tests? We use that because that allows us to control for his own lab, and there are differences in the lab parameters around the world. And a PT difference of more than 1.5 second gives you a score of 25. The platelet varies, and especially in HELLP syndrome, where part of the thrombocytopenia can be affecting the platelet count without really having a DIC. That was so the platelet score is varying, and fibrinogen less than 3 grams per liter or 300 milligrams per deciliter gives also a very high score. And if you receive a score, if a patient has a score of 26 or more, she is probably having a DIC, and the diagnosis is valid. Now, there were other proposals, especially, for example, the group who study amniotic fluid embolism in pregnancy. And when they did their score, they assigned fibrinogen concentration as being less than 200 milligrams per deciliter or 2 grams per liter to be the cutoff point. However, when we took that score and implement that in our population, the sensitivity of the score was only 14.9% with a very high specificity. And that means that it identified only 13 out of 87 cases. So it may be very good in patients with amniotic fluid embolism, but since that is a relatively rare cause of DIC in patients in pregnant women, implementing it in a larger scale may be problematic, and we just decide to use a higher cutoff of fibrinogen of less than 300 rather than the less than 200 milligrams per deciliter. Now, if we take our patient that we presented in the beginning and implement the DIC score on laboratory test at admission, we see that she have a mildly prolonged PT difference of 12, platelet less than 100, that gives you another 2 points, and fibrinogen less than 3 grams per liter or 300 milligrams per deciliter, that gives you more 25 points. 39 points gives her that she is probably having a DIC. Now, this is very important because having that diagnosis in mind when the patient is admitted with only a mild bleeding and a retroplacental clot changed tremendously the way we treat the patient and how we expedite her delivery. And this we need to put in mind. Now, when we validated our pregnancy-specific DIC score versus the original ISTH score in patients with HELLP syndrome, we could demonstrate that it has a much higher area under the curve on the ROC curves, and it was and it could identify a high score was associated with prolonged hospitalization and a more complicated course and adverse neonatal outcome in patients who were presented with liver rupture during pregnancy. Now, when we made the diagnosis of DIC, we always have to bear in mind that it is secondary to a clinical condition. Now, if we don't fix or we don't treat the basic clinical condition, we cannot resolve the DIC. And in pregnancy, we can talk about sepsis, peripartum hemorrhage, abruption, severe hypertension of pregnancy, retained stillbirth, amniotic fluid embolism, or acute fatty liver. There are all causes associated with DIC. Now, when I collected the literature from all around the world about the causes of DIC, I could see that there is a difference between different countries. For example, Canada and Israel the higher contributor is placental abruption and postpartum hemorrhage, and a bit less antepartum death. While if you look at in other countries, preeclampsia and stillbirth are the leading causes. So there are differences in the causes of DIC globally, and those things may need different attention. In the developed countries, in the Western world, and in developed countries, the leading causes are abruption and peripartum hemorrhage. And I would like to speak a bit about abruption, because I think this is a mechanism that we need to understand better than anything. Early reports of the association between placental abruption and maternal diastasis and maternal DIC already published in 1901, American Journal of Obstetrics and Gynecology. So that goes in the beginning of the previous century. So we all know that connection. In our population, in the DIC groups, 49.4% had abruption, so almost 50% of the cases. And to understand how does abruption causes DIC in a mother, we would like to need the 4 mechanisms that leads to DIC in pregnancy: hemorrhage, endothelial dysfunction and platelet activation that is mainly in sepsis, trophoblast deportation and activation of coagulation cascades that are related to abruption and amniotic fluid embolism, and disruption of liver function test. Now, the trophoblast deportation, it's actually when there is a separation between the decidua and the uterine wall, there is a deportation of trophoblast that includes highly effective and active tissue factor. That tissue factor activates the coagulation constraint and generate thrombin. And if that process is not controlled and not stopped quickly, that leads to the generation of DIC, because uncontrolled generation of thrombins leads to the 2 arms of DIC. One is thrombosis, because there is less anticoagulant proteins and less antifibrinolysis activity. And the other is bleeding, because there are increased coagulation factor consumption and fibrinolysis. And on top of that, we have low platelets. So when you have increased generation of thrombin resulting from the abruption, this process can be very fast and can develop, as I showed you in the beginning, in the case, only when we see mild bleeding outside and the patient in the beginning looks clinically stable, it's already going to be to the course of DIC. Now, we wanted to study what are the components and parameters leading to DIC in women with HELLP syndrome, and this was just published now in the Journal of Maternal, Fetal, and Neonatal Medicine. We had more than 2,000 deliveries in our population cohort. HELLP syndrome was occurring in 0.16% of them, 341 cases. This is the largest cohort that was published thus far, and DIC was in 6.1% of these cases. Now, women with DIC had the higher rate of acute renal failure, eclampsia, placental abruption, and maternal death than the other study groups. And when we investigated or looked on the causes and the independent risk factor for DIC in women with HELLP syndrome, the only thing that we could really relate to is placental abruption. I must admit that this came with much surprise to me, because I was expecting to see that women with abnormal liver function test would also have an independent risk factor for DIC, but that was not the case, meaning that the contribution of the separation of the placenta from the uterine wall and the deportation of trophoblast into the maternal circulation is the driving force for DIC in women with HELLP syndrome. So if you have a woman with a HELLP syndrome who develop an abruption, please treat her with caution and be alarmed that there might be a hemostatic problem. Now, the second cause, or the second leading cause for DIC in pregnancy, is peripartum hemorrhage. If we go to Great Britain, we see that hemorrhage is the 4th number, or the 4th etiology that leads to maternal mortality, and this is data from 2013 and 15. And when we look at the causes leading, 3 of them are placental, meaning placental abruption, placenta previa and accreta, and amniotic fluid embolism. And 3 are leading because of uterine atony, delayed maternal removal of the placenta, and genital tract trauma. Now, when they inquire the quality of care, 58% of the women who died would have benefited from better care. That is a substantial number of patients. Now, this is not only in the UK alone. This is from Gary Diddley in 2012 in a seminar on thrombosis and hemostasis. 75% of patients who died from postpartum hemorrhage would benefit from better care. So we need somehow to take that into attention. And a different study by Green and Associated, they studied what are the characteristics of women who received more than 8 massive blood transfusion and more than 8 PAC cells. The leading reason was uterine atony, following by placental reason. Again, the 3 stars, accreta, abruption, and previa. And laceration and extension of tears, especially trauma to the vaginal birth canal and uterine rupture. Inquiring the cases, 73% of them would have benefited from a better care. So in the care of bleeding obstetrical patients, we are not doing that well, and that is globally. We need to improve our performance. When they drilled down and looked at the reason and etiology for suboptimal care, the leading cause was the lack of recognition of hemorrhage, because we often fail to recognize that that woman is bleeding. She delivered, the placenta didn't expel, and the woman is bleeding out, and nobody, and people are not looking at that on one hand. On the other hand, we had acute bleeding, and we underestimate the amount of bleeding during surgery, and that can lead to a hemostatic problem later on. Now, untreated hemostatic problem, untreated coagulopathy will always lead to DIC, whether that comes from hematologic malignancy, trauma, sepsis, or cancer, or pregnancy-related factor. If we don't treat the coagulopathy early and fast, we will end up in DIC. Now, the treatment, usually massive transfusion protocols that can activate it, and I think that in many of the hospitals today in the world, this is going into a work protocol that you pick up the phone and say, especially in the hospital setup, I need a massive blood transfusion protocol, please activate that, and you start getting the protocol. We usually use the ratio of 1 PAC cells, 1 FFP, and 1 platelet, 1:1:1 ratio, and that should be given and stopped only when your bleeding is controlled, hemodynamic are stabilized, and we don't need any more vasopressor treatment. So massive blood product transfusion protocol are essential to control coagulopathies during pregnancy. And of course, without COVID-19, we cannot do without COVID-19. And the COVID-19 coagulopathy in pregnancy, there was a case report from Canada describing 2 cases who mimicked HELLP syndrome, but when you looked at their coagulation profile, they both had an abnormal pregnancy-specific DIC score. Both needed blood product transfusion. Now, that led a flag to an alarm, because most of the DIC cases reported in COVID-19 were actually with a different phenotype of coagulation and thrombosis rather than coagulopathy. And this leads to a different type of DIC that we have, what we acknowledge today, is that when you have an underlying condition for DIC, there can be a procoagulant DIC, as we see in the non-pregnant patient with COVID-19, that we have predominantly thrombosis rather than bleeding. There is a subclinical or non-overt DIC, which is the topic of a different talk. And then we have a hyperfibrinolytic DIC, which we see mostly in pregnancy, and that is predominantly with bleeding. Now, so in the non-pregnant state, patients with COVID-19 have frequent DIC, which is more of thrombosis, in 71.4% among the non-survivors, and rarely associated with bleeding, while during pregnancy, it's very rare, mostly associated with bleeding, and reported only in less than a third of the cases with maternal mortality. So that's a difference between pregnancy and non-pregnant state. Now, there is a consensus-based recommendation of the International Society of Thrombosis and a registry that deals with coagulopathies of COVID-19 in pregnancy. And the recommendation is that when you have such a patient, look at the PT-PT difference. If you have a more than 1.5 difference between the patient and control, you have a coagulopathy. Fibrinogen, low fibrinogen below 3 grams per deciliter, low platelet count, markedly elevated D-dimers only when they are several fold above the normal to the pregnancy, and you need to look at your lab to see what is the standard for pregnancy, and use the DIC scoring system that will help you to clarify whether or not the patient has a coagulopathy. What I wanted to add is that in 2018 in Venice, I presented our DIC, International DIC Registry. It's part of a combined effort with the International Society of Thrombosis and Hemostasis to improve the recognition, treatment, and knowledge about DIC in pregnancy. So we initiated the International Registry. So far, we have 117 cases from 11 countries. The blue stars are countries that already contributed to the registry. The light blue star is places where we are planning to collect more information, and all the participants here are invited, and we would like them to join us in that effort. When we look at the characteristics of what we followed, what we collected so far, we see that most of the contributors were with hospital between 2,000 to 10,000 deliveries a year. They had between 1 to 2 to 10 cases of DIC, most of them, several had more. The leading pregnancy complication of patients with DIC, again, is abruption, as we spoke. Stillbirth, preeclampsia, and preterm labor, and HELLP syndrome comes lower. Most of the patients had overt bleeding, and it's mainly in the antepartum stage. So the patient comes bleeding in the antepartum stage and develop DIC more than that on the postpartum. The leading causes of antepartum DIC were HELLP syndrome, placenta previa or accreta, chronic placental abruption, and uterine rupture as the leading causes. While when we diagnose postpartum DIC, postpartum hemorrhage, mainly because of uterine atony and placenta accreta, were the leading causes for that DIC. But on the postpartum cases, we also had cases of preeclampsia, congenital TTP, chorioamnionitis that led to sepsis, and cervical tear. 60% of the cases of postpartum hemorrhage were during cesarean section, suggesting that we need to be very careful in how we evaluate how much the patient is bleeding during surgery. Most of the patients had abnormal coagulation tests, and the DIC, the pregnancy-specific DIC scoring system was abnormal in these cases in 50% at admission and about 80 to 90% at delivery. Most of them received packed cells and fresh frozen plasma. The average, the most prevalent is about between 3 to 4 transfusion unit. And this is where we conclude. So we had start gathering the data. We are looking for further contributions so we can drill down and improve the knowledge and how we treat these patients. And we would like you to invite everyone who listens and participate in this session to participate in the DIC registry, just to follow the International Society of Hemostasis website, insert the patient data, one patient at a time. And if you need any further assistance, you're more than welcome to contact me. Thank you very much for listening.
Thank you very much, Professor Redes. This was a fantastic presentation. I really enjoyed, and I would like to. I'm very grateful for you to highlight the importance of early detection of PPH in order to avoid getting to the point of DIC. That is quite it's a fatal complication. And just a quick question, because we have for Dr. Sergey, we have a compliment for you in the question and answer, and for Dr. Ofer Erez. Just a question, have you seen an increase in the incidence in the thrombotic DIC after women's trial, after the extended use of tranexamic acid, or not?
No, we haven't seen that. In our center, the anesthesiologists give them as a prophylactic to almost all cesarean sections. We haven't seen more thromboembolic event after that.
Okay.
And we haven't also seen a change in the profile of the DIC in cesarean section.
Okay, thank you very much. Okay, now we'll hear about peripartum acute abdomen from Professor Wolfgang Henrich. He is the director of the Department of Obstetrics and the head of the ultrasound division at the two charité campuses, Virchow Clinic and Campus Mitte in Berlin, Germany. He's also the president of the Society of Obstetrics and Gynecology in Berlin and a member of several national and international societies. He has more than 500 national and international publications. Thank you very much, Dr. Henrik, for being here.
Thank you, Daniela. Thank you so much for your introduction. And I want to thank Giancarlo especially and Roberto Romero as well for the invitation to give a talk about acute abdomen in pregnancy on this great birth congress. So as you can see here, my team at one campus, in the upper picture, we have in Campus Mitte 2,000 deliveries, and in the other campus 3,500. So with 5,500 deliveries, we are the biggest perinatal center, the largest perinatal center in Germany. And if you look to acute abdomen, the prevalence is 1 in 500. So that would mean in a hospital with 5,000 deliveries or a little bit more, you can expect 10 to 11 of these events. So this is not so much. Anyway, we are a high-risk perinatal center, so we might see some more because we are a referral hospital. But at the end, there are the rare cases of acute abdomen you have to diagnose properly, because if you have a delayed, it can lead into a life-threatening disease. If you overdiagnose, it might lead into unnecessary prematurity and unnecessary C-sections. So I want to start now with a case series of 8 to 9 cases, which are the most common reasons for acute abdomen in pregnancy. But the first case is really a very rare case. This was a 26-week pregnancy. A lady, she was the woman of the wife of a cardiologist, and they were on vacation in Italy. And she suddenly experienced severe abdominal pain in 26 weeks. And her husband said, we have to go to Berlin back. So she went on the airplane and she came to our hospital and had this severe pain. And we did an ultrasound transvaginal route and saw this small cystic structure in the left lower quarter. So the majority of you will say, oh, this is a small cyst and it could be just an ovarian torsion. But always, if you see a cystic structure, I recommend to use color Doppler, because some of these cystic structures are not tortuous ovaries. Some of these structures can be a vascular reason, and this vascular reason, to say already the diagnosis, was an pseudoaneurysm of the uterine artery. So the question was now how to manage this case. We went to interventional radiology and did an embolization of this pseudoaneurysm because it was just before rupturing. And now you can see here the result of the embolization. This is a hyperechogenic Giel foam the radiologist infused into this pseudoaneurysm. And there was no harm to the placenta, to the baby, to the CTG or anything else. So the lady recovered perfectly and she received a C-section 12 weeks later, but actually due to breech presentation. Otherwise, we would have let her to deliver spontaneously as well. So pseudoaneurysm or aneurysm of vessels can occur everywhere, in the brain, in the liver, in the spleen, in the kidney, in the uterus, and as well in the ovaries. And I have seen several sudden ruptures perinatally or peripartum or even postpartum in cases with unknown sudden drop of hemoglobin and sudden onset of blood pressure drop. So, but now I want to encourage, especially our young doctors, not to look only to the baby, and the fetus in ultrasound. I will give you an overview that you can do fast sonography as an obstetrician as well, and you do not need radiologists or other imaging techniques to see in 90 seconds the whole abdomen of mothers. And you can see here, this is the postpartum scan where you can scan the uterus. This is empty already. The bladder is quite full. And now you can see it in transverse, the uterine cavity and the full bladder. So this was a postpartum case. And now we go to the right upper quarter and you can see the liver, you can see the kidney on the side. You can watch if there's any hematoma in preeclamptic patients. We come a little bit later to this view as well. You can look to the Morrison pouch, which is the area here between the liver and the kidney. You can see as well the gallbladder to rule out stones or sludge or any reason. You can see this is a very simple machine. It is a laptop machine which is available on the delivery ward nowadays everywhere. Now you go just to the other side to rule out that there is any dilatation of the kidneys, of the pelvis of the kidney, if there could be a stone, for instance. You look also to the spleen. The spleen is an important organ to look after because in patients with trauma, accident trauma, bicycle trauma, they can have sometimes secondary bleeding from the side. Now, this is one of my major favorite views, transxiphoid view. And you can see here the right ventricle, this is the left ventricle. If you have pulmonary embolism or amnion fluid embolism, or if you have a mitral insufficiency, easily to perform this view by an obstetrician, if you know this is the right ventricle, the other hand was the left ventricle, and you can see at the pancreas as well. So teach your young assistants to do it by themselves, especially if the patient admit with acute abdomen, and you can detect with a little bit of experience, you can detect a lot of the diseases by yourself. So now I want to go through the most important reasons and cases, and all of these cases I experienced myself. So I was always there to take also the pictures. So the first major important thing is that if you have an acute abdomen, 50% of all of the cases are due to appendicitis or small bowel obstruction. So let's the first case, 43 years, since 3 weeks, mild right upper quadrant pain. It was initially periumbilical pain, mild nausea, mild increase of C-reactive protein and leukocytes, and the antibiotic medication. There was a slightly decrease of the infectious parameter and the symptoms. However, during the hospital stay, she developed more pain again. So we decided in that case to do a C-section, but I will show you before, this is a typical image or loop of a perituflitic abscess. You can see irregular formation with edema around, central hypoechogenic fluid and gas. So this is a typical image of an abscess. And in that case, we did not perform laparoscopy. We performed a C-section. I will show you in a second. But you have to take into account that the appendix is rising up in correlation to the pregnancy duration. So as far the pregnancy lasts, as higher is the position of the appendix. This we already know. And therefore you have to be very careful also because of the size of the uterus. You can see with 16 weeks, it's small, and you use for laparoscopic treatment. You can use these incisions with 28 weeks. You have to go much higher not to perforate the uterus. And this was now our case. You can see here the appendix from this case, and we performed a simultaneous C-section with 36 weeks. So the second case I want to show you is another case with a chronic appendicitis. In this case, the colleagues tried to deal or to treat it conservatively. So they gave antibiotics for several weeks, but as you can see here, then with 36 weeks, we had a disastrous ascites where we had a lot of adhesions, a lot of pus and infection and adhesions. So the appendix was fixed on the uterine wall, and it was quite difficult to do surgery in this case. So one of my take-home message for appendicitis is do not treat it conservatively, as nowadays some surgeons recommend in non-pregnant women to avoid operation in acute appendicitis. You should do operation in pregnancy, from my perspective. So the next case, 34 years, dichorionic twin pregnancy, 27 weeks. Since 2 to 3 days, nausea and vomiting. Lab parameter, absolutely normal. She had upper middle quadrant abdominal pain. And now the important question is, what is the history of the patient? If the history of appendectomy, then the small bowel obstruction becomes highly suspicious. So again, acute abdomen, ask, do you have the appendix? Yes, I have the appendix. Think of appendicitis. If the patient had already appendectomy, the next probability is a small bowel obstruction. So, and then as an obstetrician, you can take the ultrasound and see the signs of a small bowel obstruction very easy. This is a dilated loop. There's no peristalsis in. There is a lot of free fluid already around these loops. And in the next image, you can see here this stiff loops. There is no movement and a tremendous thickening of the bowel, of the intestine wall. So this is typically for a severe small bowel obstruction. And we performed at the same night the laparotomy, and you can see here a necrotic loop. And the surgeon said a couple hours later, she would develop 4-quadrant peritonitis with a high probability of maternal death. So don't miss this small bowel obstruction. Take your ultrasound machine. You do not need anybody else as your brain and your probe to see dilated loops with free fluid. So this patient underwent then 10 weeks later spontaneous delivery of her twins. So again, you need not to do C-sections in such patient. Keep the uterus closed, leave the babies in to avoid prematurity. And this was the specimen of this patient. So the third case, acute abdomen, 35 years, 39 weeks. Since 12 hours, acute morphine-dependent thoracic back abdominal pain, maximum in the right upper quadrant. Leukocyte, moderate increased C-reactive protein. So interestingly, we had a couple of days before a patient with an acute aortic dissection. And the consultant on call said, oh, I hope that she won't have an aortic dissection as well because she has back pain, abdominal pain. So this is a typical psychological problem of doctors. If you have just 2-3 days before a very tremendous case, in the next 3 days later, you think, oh, this patient might have the same. But that is obviously not typically, because it is always something different. But ultrasound can help you. You look where is the major pain, and the major pain was below the rib on the right side. You put your ultrasound probe, you see the liver, you see the gallbladder, and the experienced sees sludge in the gallbladder. And the very experienced sees the gallbladder stone. Here's a stone with the hypoechogenic shadowing. And in this combination, acute pain, leukocyte, a C-reactive protein, it's a high risk to develop pancreatitis as well. So these patients have to have surgery. And because the risk of pancreatitis is tremendously increased if you have stones, and you have to, and it's recommended to do laparoscopic surgery, or as in our case, she requested for C-section. And you can see here, now we perform the C-section, how we do it in the Charité, we do it that the mother can see how the baby is delivered, so-called Charité way. Now the father can cut the umbilical cord, and then in that case, the baby goes to the neonatologist because she felt asleep, and then we called for the surgeons, and the surgeons are used to do laparoscopic surgery. So what they did, they used our incision site of the Pfannenstiel to put this excess, and then they started their typical laparoscopic operation. And so we avoided the longitudinal vertical laparotomy, and they were able to resect the infected gallbladder by this excess. So we come to the next case, 34 years, BMI very high, and since 6 hours, massive upper abdominal pain and back pain, nausea, no vomiting, no contractions, no fever, diarrhea or dyspnea. Blood pressure fine, heart frequency, saturation, everything normal. So in that case, we were a little bit unclear because she had a general painful abdomen, especially deep palpation in epigastrium. So when we took blood, we saw immediately a high proportion of fat in her blood. So the diagnosis was made actually by laparotomy, by lab parameters. So high cholesterol, high triglycerides, slightly increase of the liver enzymes, but 900 lipase and C-reactive protein, etc. So the diagnosis was clear, and pancreatitis is a very severe disease in patients in pregnancy. So C-section, morphine, and plasmapheresis is recommended. So when we opened the belly, we saw this fatty ascites in her abdomen. And so after C-section, she went immediately to intensive care to do plasmapheresis to remove all the fat out of her plasma. Next case. So this is a young patient. She explains actually in this loop her own pain. She is pregnant 27 weeks with a single pregnancy, and she was in another hospital and referred to our hospital because of suspicious of hydronephrosis. When we performed ultrasound, we saw a mild dilation of the renal pelvis. However, we saw some sludge without any gallbladder stones. And then we saw in the right lower quarter this cystic structure. And typically for ovarian torsion is that because of the shortening of the infundibulum is that cystic structures become closer to the abdominal wall. And when you do ultrasound and when you are experienced, you also can see the tortuous vessels, the torsion of the vessels of the ovary. And so she underwent in pregnancy laparoscopy, and the colleague from our gynecological department, they did laparoscopy and removed the cyst, retorquated the ovary and left the ovary in, and she also delivered 10 weeks later spontaneously her baby. So sometimes huge tumors also can lead to abdominal pain, to severe abdominal pain. In this case, she was also 27 weeks. She had in the left upper quarter this huge cyst here. You see here the right ovary. This is normal. If you can't find another ovary on the left side, this cystic structure might be typically an ovarian tumor. So what we did, we performed a high vertical incision in the upper abdomen and removed this huge tumor. This was a benign ovarian tumor. We removed it and we left her pregnant. So we closed the abdomen in pregnancy. This was the healing 8 weeks later, and she delivered as well spontaneously her baby. And in that case, it was the same acute abdomen with an ovarian tumor, as you can see here. And we performed intraoperative ultrasound to after exteriorization of the uterus, and we look to the fetal heart, everything was appropriate. You have to do very gently with that. You won't have any problems with preterm delivery or placental abruption. And then you can remove this tumor as well in pregnancy. And she as well delivered spontaneously, because we always want to avoid simultaneous prematurity. We want to avoid the uterine scar for subsequent pregnancies, etc. So, and now we come to the uterus. Okay, sometimes you have a huge myomas, fibromas, as this here. Very often they don't do anything. Just leave them in without, when they have no problems, and just leave them in here in an early pregnancy. However, sometimes they can lead to necrosis, as here in a 24-week pregnancy. And you can see this necrosis by these fluid components in this huge fibroma. And this had to be resected. And unfortunately, this lady had, after resection, late abortion. Another very interesting case was this. The lady came in 35 years, in 18 weeks, with hemoglobin of 6, pale, severe abdominal pain, blood pressure was 80/40, tachycardia with 140, and we did an immediate ultrasound, and we only saw a huge myoma. So she went for laparotomy, and we saw a huge myoma, fibroma, where a venous vessel ruptured spontaneously in pregnancy. We removed the myoma. She had 2 liters of blood loss in her abdomen, and pregnancy continued, and she got a C-section then with 36 weeks, unremarkable, without any problems. So be aware, every vessel in the abdomen can rupture, especially also venous vessels on myomas, as well in cases with endometriosis. Also endometriosis cases, they can have spontaneous rupturing of vessels, and you have to be aware, and a simple ultrasound seeing the free fluid in the abdomen can lead you early to the correct diagnosis. And now I come to Offer. You gave a great presentation about placental abruption. This is a case. She came in with 35 years old, sudden, a little bit bleeding, pale, hemoglobin of 6, blood pressure dropped, and we performed immediately an ultrasound. As you can see here, this is not a myoma, and this has to be distinguished. And we said it is a placental abruption, and we immediately went to surgery, because in these cases where the fetus was already dead, you should not postpone the delivery. You have to do immediately C-section. You cannot do any trial of vaginal birth in these cases when you have such huge blood loss into the uterus. And as you can see here, we started immediately to start with sulprostone, aggressive treatment to avoid DIC, because you can see in a second the huge clot, and this means the consultant on duty has to tell the anesthesiologist, give blood, give fresh frozen plasma, even 4 fresh frozen plasma and 2 red blood count, give platelets, give fibrinogen, give tranexamic acid, and start immediately with the best uterotonic you have. Because if you start with oxytocin in such situation, you might dilute the patient more, and with aggressive treatment, immediate aggressive treatment, you can save the uterus, etc. I will come to the last 2 or 3 cases. I hope I have the time. So this is an acute abdomen postpartum. This was a lady, she had a C-section, and the next day she exposed this abdomen. And if you see this huge abdomen, it's obviously has something to do with the bowel. So we did further image a CT here, and you can see this huge dilated colon and this typically O-shaped abdomen. So this is the so-called Ogilvie syndrome. It was Sir Hanniger Ogilvie, 1948, who described it at first. And our case was 33, a young patient with distension, vomiting 2 days after, it was the second day after C-section, and she had a so-called pseudo-mechanical bowel obstruction. So this is confirmed when you have more than 10 centimeter diameter of dilated large bowel. And as you saw, the symmetrical O-shaped ballooning of the abdomen is typical. So what is the reason for that? It's an imbalance of the parasympathetic and sympathetic control of bowel peristalsis due to bowel handling during surgery or the effect of anesthetics. So the problem of late diagnosis is that this bowel can rupture. I have seen one case where the large bowel ruptured. This can lead to severe peritonitis, 4-quadrant peritonitis, and this can lead to a mortality rate of 50%. The only chance is bowel stimulation, neostigmine infusion, decompression by colonoscopy, and to be very, very careful and ask for a surgeon to assist you to solve this problem. Now, I think the last two cases, very mild problem. Actually, a nephrolithiasis can mimic an acute abdomen by paralysis of the intestine, but it's not a direct acute abdomen reason actually, but you have to be aware of stones as well, especially in dilated renal pelvis. So look always to the kidneys, look to the urinary, if you can see microhematuria or macrohematuria, and if there is a history of stones as well. So I want to conclude and come to the end. I would have one more case with a posterior circulation, but I think because of the time, I will try to finish here. First of all, train your assistants in fast sonography of the abdomen, because if an acute patient comes to emergency room, it is typically that they send patients at first to the obstetric department because they don't want to have to do anything with pregnancy. They are afraid to harm the baby. They are afraid to kill the mother. I don't know what. They send all these ladies immediately without seeing them to the obstetrical department. The second thing is, keep in mind, it is quite easy if you rule out the direct genital uterine reasons like contractions, cervical shortening, etc., or even just birth contractions. You have to keep in mind that you have already in 50% the diagnosis if you think on appendicitis or small bowel obstruction. And then follow the way of your ultrasound probe. If the pain is in the area of the liver, then you look to the gallbladder. If there are stones, if there's a history, you take your finger under your probe and press deeper. And if she says, yes, this is a point, then it has something to do with the liver, or in the majority of cases, with the gallbladder. And if you see nothing in the upper quarters, in the epigastrium, you have two differential diagnoses: the pancreatitis or a perforated gastric ulcer. I have seen one case, but I did not visualize that. You have also keep in mind this disease, which also can occur, especially if you overdose. Painkillers, which might harm the gastric wall. So if you see an ovarian cyst, you look exactly, put your finger under the probe of your ultrasound machine, and when the maximum of pain might be there, then it has obviously something to do with an ovarian cyst. And look at myomas, if they are necrotic or not, and if you have the maximum of pain there. And now the colibris are vessel diseases. If you find a cystic structure, put color Doppler on it, and you might see pseudoaneurysms, and they can occur antenatally just during, they can rupture during delivery, and sometimes they can occur weeks later after complicated C-sections by suturing the uterine arteries inappropriate. So late uterine pseudoaneurysms can occur as well. And the major strategy in these cases is interventional radiology. So thank you so much for your attention, and thank you so much for the Congress.
Wolfgang, thank you very much for that incredible collection of cases. You came to the Birth Congress in Venice and showed an incredible collection, and this is a new collection. So I want that you never cease to amaze us. Thank you. Ofer, we'll get back to you with some questions. So Wolfgang Heinrich, chair of the Charité, giving us a spectacular lecture every year. Thank you. Thank you, Wolfgang.
Thank you, Roberto. Thank you so much.
It is a great pleasure to welcome Alfredo Perales, who is professor of obstetrics and gynecology at the University of Valencia. He was expected to host us in Valencia this year, and he's going to speak about acute cervical insufficiency and the role of cervical cerclage. Alfredo, welcome.
I think this is not working.
It's working well, Alfredo.
Alfredo, we have this.
Yeah. We can see very well.
Can you see?
Yes.
Yeah, very well, very well.
The slide? Okay.
Perfect.
Okay, thank you. Well, thank you, Professor Romero and Vázquez. I would like to thank the organizer for the invitation and the audience for attending the conference, of course. Well, the COVID has made it impossible to enjoy the meeting in person. However, I hope in the future we have more opportunities to meet each other in Valencia. Well, sometimes 1 month ago, a 44 years old pregnant woman who underwent IVF and oocyte donation came to the emergency department with discomfort in the hypogastrium. Ultrasound examination revealed bulging membranes protruding into the vagina. And in relation with this case, I want to present our experience in these particular cases. Well, all you know that bulging membranes are a severe degree of cervical insufficiency. Despite the existence of several etiologies, inflammation and infection are the most prevalent, being the frequency and severity greater as at early gestation age. In this situation, emergency cerclage is the only treatment that can prevent the fetus to be delivered too early to survive. This is a prospective study we have been doing during many years of single-term pregnant women presenting with bulging membranes from 16 weeks until 26 weeks gestation, who were admitted to our hospital. According to the hospital protocol, the patient underwent an examination and a transvaginal and transabdominal ultrasound in order to evaluate the cervix, rule out fetal malformation and confirm well-being and check gestational age. Subsequently, maternal blood samples were obtained and an amniocentesis was performed in order to rule out the existence of subclinical chorioamnionitis. You can see how, according to our protocol, we determine the exclusion criteria, those are the parameters, and how we diagnose amniocentesis, namely with the level of interleukin-6 in amniotic fluid greater than 2.6 nanogram per milliliter. The other are also other parameters we take into account. Well, there is an agreement to consider that values over 2.6 are clearly related to the presence of either mild, severe, or infection, and how these levels are related to the latency to the delivery. The greater the level of interleukin-6 in amniotic fluid, the shorter the interval. All patients with bulging membranes were offered amniocentesis, and nearly all accepted the procedures. according to the criteria for cardioimmunity based on amniotic fluid values, we classify them in two groups. The first group includes those, the third class group. We include the patients who had not chorioamnionitis, and then we perform on their, well, we give tocolytic, we also antibiotics, and we perform the cell clash. Those patients were discharged 48 hours after the procedure. Well, then the patients underwent follow-up every 2 to 3 weeks till delivery. The other group was the expectant group, and those patients that were known by the interleukin-6 by subclinical chorioamnionitis, and those patients underwent similar protocol but without cell clash or placement or tocolytic. Well, here, in summary, we had 26 cases, 25 cases in which interleukin-6 was lower than 2.6. We can see, as in those that we performed the cell clash, the delivery was later than those that do not perform cell clash that has interleukin-6 greater than 2.6. Well, we can observe a longer latency to delivery as well as newer weight in cases in which in amniotic fluid interleukin-6 was lower than 2.6, amniotic fluid culture was negative, or we perform cell clash. In contrast to the opposite situation, interleukin greater, positive culture, and no cell clash. Also, we wanted to know other parameters that could be related, and we found an association between interleukin-6 in amniotic fluid with latency to delivery and newer weight, as well as C-reactive protein in the maternal blood. And also the glucose in amniotic fluid was associated. The ability to predict outcome of different maternal amniotic fluid parameters, we wanted to evaluate the possibility of biologistic regression. And we wanted as outcome a stillbirth, newborn weight greater than 1,000 grams, 1,500 and 2,500, as well as the birth weight post 28 weeks and 32 weeks, and as well as 34 weeks. We can see that gestational age of diagnosis and cell clash were associated significantly with all the success of the outcome, but not in the case of newborn weight greater than 2,500 grams or birth weight beyond 32 weeks. Our findings were in the line with a paper that is published in Acta Scandinavica from this group from Greece, that we find that decreasing preterm births with cell clash found a decrease in preterm births, prolonged pregnancy, decreased neonatal death, and fetal losses, not increases the risk of chorioamnionitis and premature rupture of membranes. Well, let's focus our attention on some questions. Could amniocentesis be avoided? This is, why should we perform an amniocentesis if we can have maternal markers? The second question is, which is the best antibiotic protocol? The third is, which tocolytic is the best? The fourth is treatment for twins similar to that applied for Signeton, and we can just obtain similar success? And in regard to the latter point, in twins, should we sample the Boltzmann sac or both? Well, to the first question, if we can just avoid amniocentesis, we sample in 9 cases in twin pregnancies, amniotic fluid for interleukin-6 and vaginal fluids for interleukin-6, and there was no association. This is, vaginal interleukin-6 is not a good predictor of what is happening in the amniotic sac. Then we perform a comparison of inflammatory markers, maternal inflammatory markers, white blood cells, C-reactive protein, fibrinogen, and neutrophils. We find that white blood cell and maternal C-reactive protein are associated with latency, delivery, and newborn weight, but those were were somehow similar to amniotic fluid. Then we wanted to perform root curves to estimate the diagnosis ability of interleukin 6 C-reactive protein. Well, this was okay. Sorry, C-reactive protein and white blood cells. Here we only show the comparison of the root curves of amniotic fluid interleukin 6 and CRP. In all cases, for predicting perinatal death delivered at 20 weeks, more than 32 and 34, newborn weight more than 1,000, 1,500 and 200. In all cases, interleukin 6 was greater for in his diagnostic ability for the diagnosis of chorioamnionitis. Pertaining to the antibiotics and thrombolytics, there is positive data regarding the best option for treatment in cases of bulging membranes. From empirical data, the combination of indomethacin, metronidazole, and also cephalosporin and macrolides might be a promising combination. Well, the other question is if we can just follow the same management in twin pregnancies similar to single-term pregnancies. We have a group of 21 twin pregnancies. In 6 cases, interleukin 6 was lower than 2.6, and we performed CERCLASH. And as we can see, similar to in single pregnancies, in those pregnancies, the birth was at later stages, later than 32 weeks, in contrast to no CERCLASH. Also, we went to perform a similar analysis, performing how was the discriminatory points for interleukin 6 culture and CERCLASH. And we can see that amniotic fluid lower than 2.6 has an increased latency to delivery than if the interleukin 6 was greater, newborn weight in both cases, as well as the amniotic fluid culture. When the amniotic fluid culture was negative, the latency to delivery as well as the newborn weight was greater when the culture when the culture was negative. CERCLASH is the same, but as you can see, the numbers, the data is just the same. And this is because we perform CERCLASH in the cases in which interleukin 6 was lower than 2.6. Also, we want to know the association, the pre-CERCLASH risk factors for in twin pregnancies with bulging membranes. And we only find association of amniotic fluid glucose and CRP. But when we put together all the maternal factors as well as the amniotic fluid factors and we perform a logistic regression, there was no predictor of the outcome. Those results are also in line with those published by Roman that CERCLASH indomethacin antibiotics were associated with longer latency period, decreased spontaneous preterm birth, and improved perinatal outcome when compared with the expected management. Also, we wanted to compare the efficiency of CERCLASH in single and twin pregnancies in terms of interval to delivery. In both cases, CERCLASH was associated with a longer interval to delivery than if no CERCLASH was done. Interestingly, the curves are overlapping each other when CERCLASH was performed or not. And also the confidence intervals overlap. The same applies when we want to see one for the delivery in terms of week. The curves are overlapping each other. In regard to the last point, we wanted to know if we need to sample just the site of the bulging membranes or both. And in 14 cases, we compare the data for the amniotic fluid, and we find an association of interleukin 6 in both sacs, white blood cells, and LDH. The most important interleukin 6, we think that could be used only this data because in the first sac, in 7 cases of 12, there was greater. In four, they were the same, and just 1 was in the second sac lower. And this was because in this case, the first sac was 0, but there was an 0.1, which just fell within the variability of the biochemical assay. In conclusion, in singleton pregnancies with bulging membranes, amniotic fluid markers predict more accurately than the outcome of maternal markers. Interleukin-6 is a good predictor for pregnancy outcome, mortality, latency to delivery, gestational age at birth. Amniocentesis and cell clash appear to be the standard of care. In twin pregnancy with bulging membranes, amniocentesis and cell clash are as effective as in singleton pregnancies. And sampling the amniotic bulging sac provides information for decision making. Thank you very much.
Thank you very much, Dr. Alfredo Perales. You have some questions here. Thank you very much for this fantastic presentation. You have some question here. Until what gestation week you prefer cell clash?
26 weeks. We perform cell clash between 16 to 26 weeks.
Okay. Thank you so much. Here is Dr. Romero.
And we have some questions for the group. Let's begin by Ofer. Can you tell us something about compensated intravascular coagulation or non-overt DIC? You just published a paper. What is non-overt DIC?
Well,
Why?
Dr. Romero, thank you for the question. The ISTH in their DIC the definition divided the patient into 3 groups: those with normal coagulation system, a patient with overt DIC that usually have bleeding and come with very clear clinical pictures, and those who have underlying hemostatic disorder and they are non-overt DIC. We took that concept and tried to implement that in pregnancy in order to identify patients who will benefit or who will require a blood product transfusion. And what we were able to see, and we use different parameters. If I can share my screen, I can show that. I think.
So let me ask you a question. So, okay, good. You have it there.
Yeah, and what we did is we employed a different set of parameters, and we were able to show that patient who had a non-overt DIC score, a positive non-overt DIC score, and a risk factor, for example, HELLP syndrome, abruption, or that, we could identify them upon admission before even they had the clinical diagnosis. So, actually what we are saying is that if you take the right coagulation parameters at admission, you can identify patients who will later require blood product transfusion, even among normal pregnancy. Now, this observation is very preliminary. And when you run all this panel of tests, including thrombin, antithrombin complexes, PT, D-dimers, it's quite expensive. And I think that the next step is to find a way, maybe using thromboelastography or other methods that are point of care testing and much cheaper, to identify and to screen the patient earlier at the stage of labor in order to induce intervention later on the stage or before we have a problem at hand.
Thank you. Wolfgang, that you want to make obstetricians into people who can do imaging with ultrasound of the entire pregnancy. Is this part of your curriculum, training for your residents?
Absolutely, because I think the new generation of obstetricians, they are used really to use the ultrasound from their first day on. And therefore they are used to look first trimester, neural translucency, nasal bones, etc. Intracranial translucency, we teach them in the first month already when they are doing their rotation in obstetrics and fetal medicine. So abdominal ultrasound is quite easy, but you have to go over this limit that you say, okay, I trust myself also to look to the liver, to the kidney, to the abdomen of free fluid, to the intestine. And what I always teach them is at the end of a normal screening as well, I'm doing it by myself. I try, actually, it needs just 1-2 minutes to see both ovaries on the side, to have a short look to the liver, to have a short look to the kidneys. And sometimes you really detect some things. You have to be careful also not to overinterpret and overtreat or make confuse. But it's a teaching aspect. And when you have seen a lot of normal findings, then you have easily, you see the difference. And I think we are doctors and not only obstetricians, and we have to see not only the fetus and the uterus and the placenta, we have the chance to go around, and we are used to look in more smaller details than our radiologists. And so sometimes it's difficult at night to get a radiologist, to get an MRI, or to get another imaging modality. So do it, trust yourself, do it by yourself, and then you will find immediately these cases. And I really can just encourage everybody who is interested in ultrasound to do this.
Wolfgang, because you presented several cases, I would like to ask you one question. The patient who had an acute postpartum abdominal distension, Ogilvie syndrome, which is dilation of the large bowel, typically of the sequence. So the diagnostic criteria is a transverse diameter that is 10 centimeters.
Exactly.
When do you decide to operate?
Actually, this is a question which we are really decide interdisciplinary, because surgeons are much more confident with bowel, especially large bowel problems. They know this disease also from their operation. So I would not decide in that case the management by myself. I would really do it interdisciplinary. However, it is important to recognize it early, to stimulate early the intestine, and to do a rectal deflation of the intestine and to stimulate with neostigmine. And I think when we have to be careful not to touch too much the intestine during C-sections. A smoothly, gently removal of fluid and clot is possible, but not doing too much things in the abdomen, because the intestine doesn't like air, and it doesn't like to be touched too much. And one important thing, Vincenzo Berghella gave a great talk yesterday, and I think this early mobilization, this early fluid, oral fluid and chewing gum, to chew and to stimulate physiologically the intestine, the early removal of catheters, all these are measures to avoid this intestinal problem. However, this majority of the small bowel, this large bowel problem might be really a rare complication of the spinal anesthesia, and you have to be aware. I have seen only one case where we needed operation. They opened the belly and removed with a needle the air out of the intestine.
Great. So thank you, because this is the type of things that we need to learn, and your pictures were extraordinary. I also have faced one case, and the most difficult question is when to operate or not. And also I have the experience of, putting a needle into the second and emptying the second. I should say that the transverse diameter is measured in the second rather than other parts.
Let me comment. Let me say one sentence more. According the ovarian tumors, very often I get the question, oh, now should we do with 32, 34 weeks the C-section and then remove the ovarian tumor? This is a typical mistake. You have the problem with the ovary, not with the pregnancy. So if you have an indication for an operative intervention to solve the problem of the ovarian tumor, you need not to do parallelly a C-section and to produce prematurity. This is one of the typical mistakes worldwide done, to think, oh, we wait till 34, perhaps 36 weeks, and then we do it in one session. But this is one of the major mistakes from my perspective.
Wolfgang, just because we are in this subject, so we have appendicitis, which you cover very well and people are familiar. I saw what appeared to be a very ischemic bowel in another case that you presented. Are there any advances in the differential diagnosis of ischemic bowel disease?
Ischemic bowel disease are, we are glad that they are not often in pregnancy, because ischemic bowel disease is typically for the elder men or elder women, and not in the women between 16 and 45. So ischemic bowel disease, I could imagine that it is the best to diagnose by lab parameters, so lactate, for instance, especially lactate, and maybe by, if you have really the question, by interventional angiographic and MRI. But I haven't seen a really primary ischemic. I mean, if you have a small bowel obstruction, it is obvious that it becomes necrotic. But interestingly, in this severe case I showed, the lab parameters were unremarkable, but the intestine loop was already dead. So you have to be very careful, and I think the ultrasound signs, and then the status of the patient, and then the absolutely silent loop was the indication to do the surgery.
Great, thank you.
Professor Romero, just a quick question, quick detail. We have two short oral presentations of 5 minutes each. Would you like to move to them?
Sure. Let's go ahead, and we'll return for questions. Thank you.
No, I'm sorry, but I didn't know.
Very interesting presentations.
Yes.
So
yeah. Oh, you go ahead, please. Okay, first, we'll start with labor and delivery outcomes in pregnant women with cardiac disease, presented by Rohan De Souza from Canada. He's assistant professor of OBGYN and a maternal fetal medicine physician at Mount Sinai Hospital in Toronto.
Thank you to the organizers for the invitation and the opportunity to speak at this prestigious conference. Can you see my slides?
Yeah, very well.
Okay, thank you so much. So I've got only 3 minutes in which to speak, so I'm going to go straight to the point. When we talk about cardiac disease in pregnancy, in the last 20 years, there have been more than 200 publications on cardiac disease in pregnancy. But when we start looking for details on labor and delivery management, the number of studies are extremely limited. To be specific, there are only 12 studies that have actually talked about the details of labor and delivery management in this very complex patient. And as you can see from this slide, most of them are from Europe and North America. Some of them are national data sets where the granularity of data is missing. So they've got large numbers, but there are no specific details. They're mostly about risk factors and predictors of adverse outcomes. Most studies are retrospective. There's a combination of various types of cardiac disease. Some studies are quite old in that they have patients that were managed before the 2000s, where management was considerably different. And therefore, when you look at how many people we really have data on, we only have data on 1,958 pregnancies from which to make clinical recommendations. And this might have been okay if there was consistency in the way pregnancies were managed. But this slide shows you how inconsistent this management is. So I'm briefly going to go over this. In some studies, induction rates as high as 50%. In some other studies, spontaneous vaginal birth rates as low as 26%. In operative vaginal birth rates as high as 42% in some and as low as 3% in some others. Cesarean birth rates varying considerably as well. And most importantly,
Ой, твою мать называется. Вечером такие кадры, а я сплю там рядом с Давидовичем, мы оба спим. Давидович такой в полудреме, я сплю, глаза закрыты.
Close the microphone.
Sorry, and so when you talk about pushing, in some studies, only 27% of patients were allowed to push. And all of this makes sense when we understand the maternal hemodynamics in labor. We know how profoundly the hemodynamics change. I'm not going to go in detail about this, but we know that these hemodynamics in terms of cardiac output and heart rate changes not just with every contractions. It remains elevated between contractions and is much worse when you're pushing. So what I'm going to present is the Toronto experience with the management of cardiac disease in pregnancy. We published the contemporary approach to our management in a 2012 paper, which included 559 patients with cardiac disease compared with an equal number of comparators that were both high and low risk pregnancies. What I'm presenting today is a follow-up to that, which includes a prospectively collected data from the CARPREG data set. I've included the years 2009 to December 2018. This is compared with low risk, the lowest risk pregnant patients, not with other high risk patients. It includes congenital and acquired heart disease, various types of heart disease, and we've got 1,189 patients with cardiac disease, which makes Toronto the center with the highest number of cardiac patients being managed in pregnancy and labor. Busy slide, but what I'd like to take, the take-home message from this slide is that there are various types of heart disease that we have considered and we manage at Mount Sinai Hospital, and only 19% of them actually were in the MWHO category 1, which means most of our patients were quite sick and have complex congenital and acquired heart disease. The biggest success story for us, however, is because of a program that was begun many years ago and which is now really consolidated and functioning so well. We are able to offer preconception counseling, which means that even these very sick patients come into pregnancy with an NYHA functional class of 1 and 2. 99% of our patients begin their pregnancy with NYHA class 1 and 2. And that is the biggest secret to the success of our labor and delivery outcomes. So in addition to the optimization of functional class, the other two things that we do, I think, really well is appropriate antepartum surveillance by a multidisciplinary team and individualized care plans for the peripartum period. As a result of this, we've got excellent outcomes in labor and delivery. And as you can see in this slide, our planned cesarean deliveries, although higher than the control population, which, let me remind you, is the lowest risk population, is only slightly higher. Labor is induced in a higher number of patients, and this is because of the geography of Canada. Some of our patients live hours and hours away from our hospital, and so we don't have an option but to induce labor. However, if you look at the vaginal birth rates, our vaginal birth rates are as comparable to the lowest risk population as they can get. 85% of our patients deliver vaginally. Yes, our operative vaginal deliveries are higher than in the controlled population by twice the number, but the intrapartum cesarean delivery rates are very low and comparable to the control population. Most importantly, 99% of our patients that make it to full dilatation in the second stage are allowed to push. Although the pushing duration is lower than the control population, they are all allowed to push. So this is a snapshot of our outcomes on labor and delivery. And one might say, well, if you're doing all of this, does that increase adverse events? So to answer this question, we identified a composite of cardiac, obstetric, and perinatal adverse events. And I'm going to show you in the next slide what the rates of these events were. So the maternal cardiac events, there were only 3% that ended up with cardiac events in labor and delivery. There were 8% had maternal obstetric adverse events and 14% perinatal events. The cardiac events were all predictable. No mothers died out of the 1,189. Most of the events were related to arrhythmia and heart failure. When we look at the adverse obstetric and neonatal outcomes, our outcomes were comparable in the cardiac population with the lowest risk control population, except for intensive care unit admission for non-cardiac reasons and in both mother and baby. I'm finally going to talk about the predictors of these adverse outcomes. So what we tried to do was to see what were the events, what were the predictor variables that were responsible for these adverse obstetric, cardiac, and perinatal events. Not unexpectedly, an NYHA class greater than 1 or an MWHO class greater than or equal to 3 were responsible for adverse cardiac events in labor and delivery. But what was surprising is that operative vaginal deliveries and mostly emergency and planned cesarean deliveries were responsible for adverse events in all three categories: cardiac, obstetric, and perinatal events. So it is not so much the condition, but our intervention for the condition that is actually responsible for most of the adverse outcomes. And this also can be said for perinatal events. The greatest predictor for perinatal events was preterm birth. 50% of our preterm births were iatrogenic and done because of concerns about the maternal cardiac condition. And this was responsible for most of our perinatal events, which was NICU admissions. So in conclusion, as long as we are able to optimize NYHA functional status prior to onset of labor, if regional analgesia is liberally available, and if we have individualized care plans, labor and delivery complications in patients with heart disease remain very low. The risk factors for cardiac events are expected, which is NYHA and WHO categories that are higher than 1 and 2 respectively. But what we've noted from our population is that it's not the condition, but it is our interventions for the condition that are actually responsible for most of the adverse events in this population. What are the implications for practice? Some things are not modifiable, like we cannot change the MWHO class of a person, but we can optimize cardiac function prior to labor. And this is primarily the reason why our outcomes are so much better. It's important also to try and reduce instrumental delivery and cesarean delivery rates. Pushing is not contraindicated in all patients with cardiac disease. It's a very, very small minority of patients that really cannot push. We need to get rid of this misconception that we need to shorten the second stage of labor with the use of an instrument. At Mount Sinai Hospital in Toronto, we prolong the second stage of labor by prolonging the phase of passive descent so that we can shorten the active stage of pushing. And this is also responsible for our lower operative delivery rates and for our lower intrapartum cesarean delivery rates. And all of this is made possible by encouraging regional analgesia in our patients. And finally, if safe, we should consider prolonging patients and pregnancies to as close to term as possible. Just because somebody gets to 34 or 35 weeks, bailing someone out by inducing labor or by doing a cesarean section should be avoided if the cardiac condition of the mother permits. That's all I have time for, and I'd like to thank my mentors and my collaborators in this project. Thank you.
Rohan, a very good presentation. Thank you very much. The last oral presentation of this session is the broken heart syndrome that has a proper name that comes from Japan. So let's hear from Mafalda Naranjo about Takayasu disease, or Takotsubo myocardiopathy.
So are you in?
Yeah, he's online.
Yes.
Go
Yes.
ahead.
Okay.
Perfect.
And are you seeing my screen?
Yes.
Yeah. Okay. So good afternoon. Thank you for the invitation. Today I will talk about a clinical case of Takotsubo cardiomyopathy in postpartum. Takotsubo cardiomyopathy, also known as apical ballooning syndrome, broken heart syndrome, or stress-induced cardiomyopathy, was first described in 1990 in Japan. This is a transient regional systolic dysfunction of the left ventricle without imagiological evidence of coronary artery obstruction. It is more prevalent in older women and is often triggered by an intense emotional or physical stress. The patient usually complains about acute substernal chest pain, dyspnea, or syncope. The prognosis appears to be good, with complete recovery of this systolic function in weeks with low mortality rates. A 37-year-old premipara was admitted with premature membrane rupture at 40-week gestation. The patient has hypothyroidism without pre-existing cardiovascular risk factor. A C-section was performed based on arrest labor, and no surgical complication was recorded. In the second day of life, the newborn was diagnosed with septicemia. That same day, the mother developed an headache, dependent edema, and moderate dyspnea. 12 hours after the appearance of the first symptoms, the patient had a severe dyspnea, wheezing, and retrosternal chest pain without radiation. The patient's vital signs show elevated blood pressure and low oxygen saturation room air. Analytically, the patient had anemia, cardiac troponin T, and D-dimers elevation, and type 1 respiratory insufficiency. The patient was transferred to our center. An angio-CT scan excluded pulmonary thromboembolism, but cardiomegaly and left pleural effusion was noted. The ECG showed sinus gluten without signs of ischemia. The transthoracic echocardiography showed dilatation of the left cavities and global basal and medial segment wall hypokinesis. It also showed 39% left ventricle ejection fraction. The patient started treatment with ACE inhibitors with clinical improvement. A cardiac MRI performed 8 days after the beginning of the symptoms diagnosed with inverse Takotsubo-cardiomyopathy without ischemia. With a proper diagnosis and treatment, the patient recovered quickly and was discharged from the hospital 10 days after the childbirth. At 6 months follow-up, the patient had a normal left ventricular systolic function without segmental anomalies. Thanks you for watching.
Excellent.
Thank you very much.
Mafalda, thank you very much. Lovely.
Thank you.
Should we go back to the question and answers? And let me first go back to Alfredo. Alfredo, we have a question there from one of the participants that wants to know about the natural history of patients who have no evidence of intrameiotic inflammation with and without cerclage.
Well, this is very difficult question, but in theory they will deliver quite soon, and according to the length of the cervix, we will deliver sooner. As the cervix is shorter, of course, but if you have these bulging membranes and the membranes, the amniotic sac bulging into the vagina, the prognosis is very poor.
Sure. Thank you. Daniela, do you have any questions that you want to address?
No, I could like to point out to Dr. Wolfgang that I didn't have the opportunity. I have learned a lot about acute abdomen in pregnancy, and actually was a very good lecture. The importance of using ultrasound, and another thing that for critical care physicians, as I am, like prolonging, like not to stop pregnancy, not to interrupt pregnancy, because many times it's not necessary. So I really enjoyed all the presentations, and I learned quite a lot.
May I ask a question to the excellent lecture from Rohan?
Please go ahead.
Yes.
Rohan, thank you so much for this excellent presentation. We just have 2 cases with severe cardiomyopathy, and also therefore I encourage everybody in preeclamptic patients to do the transxiphoidal for chamber view to see if there's effusion, pericardial effusion, or hypocontractility of the myometrium. However, what I want to ask you, we have 2 patients. One I performed 3 days ago in a 20-week patient with a cardiomyopathy, bilateral, biventricular. She had an ejection fraction of 19. And we performed in the German Heart Center with ECMO access and assist system access. We performed a C-section in 20 weeks. And unfortunately, the lady did not improve now. She's still on a fraction rate of 15. And there was one question if bromocriptine, which we use typically after birth, if it is possible to administer already in pregnancy. This is the first question. And the second question is, how do you explain that in this peripartum cardiomyopathy, the ladies do not often improve?
So, so first qualification is, or clarification is, I am an MFM as well, not a cardiologist, but I'll do my best to answer the questions. So bromocriptine, especially in this situation that you mentioned, is possible. The pregnancy is not continuing. The pregnancy is going to be terminated. And yes, bromocriptine has been shown to improve cardiomyopathy in some populations, in subpopulations, and therefore, with a multidisciplinary team approach and with explaining this to the patient about what the risks and benefits are, it's definitely something that can be used. For our patients that have extremely low ejection fractions, we do not do hysterotomies. We actually use dilators, so laminaria tends to dilate, and then misoprostol, because we know that just delivering rapidly does not always improve the peripartum cardiomyopathy. And also that when the ejection fraction is so low and the cardiomyopathy is so far advanced, it's not going to immediately improve. So it is going to take, it often does take some time to get back to its, the cardiac function to get back to normal after the peripartum fluid changes and shifts have all happened. So I think it's just a question of waiting before you begin to see an improvement. But a cesarean, we've found when we've compared, and this has been shown by other groups as well, that in any population with cardiomyopathies, a cesarean delivery with all the anesthetic implications, as well as the larger peripartum fluid shifts and blood loss, may take longer for a person to recover than for a person who has birth vaginally.
Rohan.
Yeah.
What is the rationale for the use of bromoergocriptine in postpartum cardiomyopathy?
Well, I remember when I was a fellow, I had done a presentation on it, and I'd be able to pull it up and pick it. I think it's got to be with the natriuretic BNP levels. It's got an effect on modifying that, and that is the main driver of it. But the exact pathophysiology, I'm sorry, I wouldn't be able to give you offhand.
Wolfgang mentioned the relationship between preeclampsia and postpartum cardiomyopathy. And there is recent evidence that soluble FLIT, the marker that we examine to predict preeclampsia along with PLGF, is elevated in these patients. And I think that bromoergocriptine is because of a role of prolactin in postpartum cardiomyopathy. Now, Mafalda, I have a question for you. Do you have, typically, when you have broken heart syndrome, there is a massive dilatation of the left ventricle. Did your patient have massive dilatation in transesophageal echo?
Yeah, she has. Yes.
And did that resolve?
What, sorry?
Did that improve?
Yeah. In the 6-month follow-up, the heart is normal in the echocardiography.
And do you want to tell everybody some examples of the high anxiety conditions that can cause broken?
Yeah.
May I ask a question to Professor Romero?
Yes, please.
Roberto, did you publish a paper with all about antibiotics in cases of inflammation and infection that prolongs pregnancy? The problem with the Golgi membranes is that we perform cell clash just when we have just no inflammation or infection. Do you think that this makes sense to perform cell clash also in those patients with infection, inflammation under treatment that you propose?
So I have 2 comments.
Okay.
First is I didn't go into details, but in many of the cases that we described in the study from South Korea, antibiotics were given, and in addition, when the condition improved, the physicians place a cerclage. So, and that is described in our paper in the American Journal of Obstetrics and Gynecology published last year. So, the second point is we are preparing a case, which I'm going to tell you about it, and I will present it soon, We had a patient who presented at 22 weeks of gestation with a short cervix. I think it was 12 millimeters or so. We did an amniocentesis and the patient was sent home, but we diagnosed sterile intraamniotic inflammation with no infection. We called the patient back, and when she came back, she had the typical acute cervical insufficiency, a massive protrusion of the membranes, no cervix left. The patient was treated with antibiotics, the 3 combination for 10 days, and the patient decided that she didn't want more antibiotics. So when we repeated the examination, the cervix had been reconstituted and there was no longer acute cervical insufficiency. Initially, the patient has sludge. So the patient decided to go home. We didn't place a cerclage, and she delivered yesterday at 36 weeks of gestation. So that means that some of these conditions appear to respond to antibiotics. So I believe, this is early. We will present this case because it's very dramatic. At 22 weeks of gestation, a short cervix, a massive amount of sludge, intraamniotic inflammation without bacteria, responding to antibiotics, it seems like, and delivering a term. We, in the experience in South Korea, we see this quite often as well. So, but this is a case that we have very well documented, because if someone, not long ago, I didn't believe that intraamniotic infection or intraamniotic inflammation could be treated. I saw that once you have this, the only solution for this is delivery. I've changed my mind.
Okay, thank you.
I would like to ask 2 questions, please. First to Dr. Marin. Dr. Marin, thank you for the great presentation. You had in the twins and in the singleton a group of patients who have elevated IL-6, but did not deliver after 23 weeks of gestation. That when you diagnosed them, they had a incompetent cervix, and then they had signs of inflammation, but they did not deliver before the threshold of viability, before 23 weeks, but they were delivered in the early preterm, between 23 to 28 weeks of gestation. Could you think that maybe these patients may have benefited from a cerclage to pull them a little bit longer in gestation?
I'm not sure, because the problem with this cerclage is that we don't give the same opportunities to those patients with inflammation, because maybe some of those patients could benefit from cerclage. But this is the question: which ones? Maybe this is the answer is the ones of giving antibiotics and then perform cerclage at the same time.
Okay.
Alfredo, one question about the twins. During your presentation, you addressed the question of twins with an acute cervical insufficiency. And you asked, when we did this study in twins, all the infections were in the presenting twin. Are you doing amniocentesis in both sacs or only in the non-present? Which sacs are you?
Both. In 14 cases, we perform in both cases, in both sacs. And
how many?
The first one is enough.
How many times did you have infection in both sacs?
I think I don't remember. I cannot say for sure now. For sure.
So when we did our study in premature labor in twins, all the infections were in the lower sac. Did you have any infections in the upper sac that were not in the presenting sac?
Well, in 6 cases, we have inflammation in both. In 6 cases, I'm looking at my slide. I think this is my 21 slide, and I have in 6 cases we have infection in both sacs. Yes.
And was there any case in which the inflammation or infection was in the non-presenting sac?
Never.
Okay. Thank you.
Never.
I'd like to ask. Oh, I'm sorry.
Daniela, please go ahead.
Okay, I would like to ask you something else to Rohan, just referring to prepartum cardiomyopathy, and could you recommend to avoid new pregnancies for your patients? Because it's a controversial issue still.
Yeah, so the policy that we take is we explain the risks of a pregnancy, but we've never really strongly, we recommend against, but we don't tell people that they should not. So we've had patients with very, very low ejection fractions conceive Eisenmengers, etc. Yeah, it's only about explaining the risks and saying this is what we recommend. But if they choose to be pregnant, we take them through the pregnancy.
Thank you very much.
May I have a comment to that? Is Wolfgang?
Please.
May I comment this? From my experience in the literature, if you really had a severe peripartum cardiomyopathy, the risk to die in a subsequent pregnancy is up to 50% due to recurrence of the disease. So, I mean, I'm an obstetrician, I appreciate pregnant women, but this is a rare cohort where I really would not to recommend to become pregnant again when they get really quite good out of this severe peripartum myopathy. I would not recommend to make another pregnancy.
So we do that. So we tell them what the risks are. So we've got, with patients of Eisenmenger syndrome, again, the risk is 38 to 50% of mortality. We've also had patients with cardiac transplants, and we know that many of them die in the postpartum period. Of the 5 that we presented, we published, 2 died at 10 months and 18 months following pregnancy. But ultimately, it's about telling them what the risks are, and then they make their choice. And they understand that they leave their children. Often they make a choice. And so if they choose to continue with the pregnancy, we manage the pregnancies.
Excellent. Rohan, I'm going to ask you one last question. Patients who have primary pulmonary hypertension, no secondary, but primary pulmonary hypertension, how do you have a proposed scheme for counseling those patients?
We've got a primary pulmonary hypertension team, and so most of the counseling is done by that team. There's Dr. Granton, who is in charge, and he's excellent, and he's the one that does most of the counseling with Dr. Candace Silversides. I'm sure there is a scheme which I could try and obtain from them and make available, but my focus is always labor and delivery. So by the time they come there, the schemes are already in place. Yeah. So.
Okay. Thank you very much.
May I make a short comment to this primary pulmonary hypertension?
Please.
We have, a couple of years ago, we had a lady with a severe idiopathic pulmonary hypertension, and she was 36 weeks, second pregnancy, and it was a very, very severe case, and the mortality was estimated approximately of 70%. And what we do in such cases, we, in advance, before we perform the C-section and delivery, we bring all the family members together to talk to them before such a delivery, because it is a major difference if you tell family members before, it must be not in front of the patient, about the severity of such a disease, and then I emphasize the patient will survive approximately in 30 to 40%. I do not say she will die in 60%. I say she will survive it in 30 to 40%. And then if such an event happens, and they happen, these events, it is much more better to understand and to accept fatal outcomes if you talk so clear before such an event with the family members. So I just an experience and a recommendation to be clear before with the family members of such a severe. Otherwise, you get easily into medical legal conflicts because family members never expect maternal mortality in advance. Never. They think, oh, they're in the best hospital, they have to solve the problem. But if they do not solve the problem, they always think at first they have done something wrong. So from my perspective, I would recommend to talk clear before. What is your experience, Rohan?
Dear Dr. Romero, I think we have run out of time, but there's one question that is for you in the chat. I'm really confused. Is cerclage in acute cervical event is useful or not? So I think we may answer this question and then.
Acute cervical insufficiency is defined as dilatation of the cervix, typically in the mid-trimester, with prolapse membranes. The best evidence that cerclage is efficacious is a paper that was published by Alcinius from the Netherlands, published in the American Journal of Obstetrics and Gynecology. They took a group of patients who presented with acute cervical insufficiency, singleton and twins. It's a small series, and patients were randomized to expectant management or a cerclage with heparin, indomethacin, and antibiotics. And that combination reduced the rate of preterm delivery and neonatal morbidity and mortality. So let me be clear. Cervical cerclage in patients who present with a dilated cervix, prolapsed membranes in the mid-trimester reduces preterm delivery and reduces morbidity. So the standard recommendation is to treat it with a cerclage. Now, when we place the cerclage, often there are complications. Patients may rupture the membranes, develop clinical chorioamnionitis, or may bleed. And what we have found is that 1 of every 2 patients who present with acute cervical insufficiency, singleton gestations, have intramyotic infection. And if we place a cerclage in those patients, the prognosis is often poor. So we do amniocentesis to identify the patient who has intramyotic infection or intramyotic inflammation. If patients don't have it, generally they do well with a cerclage. If patients have infection and inflammation, we are aggressive with antibiotic treatment. And I described that in some cases, we can place a cerclage as after the patients have responded. And I described one case in which with acute cervical insufficiency and sludge and intramyotic inflammation, the patient did well and delivered a term, even without placing a cerclage. So I hope that that answers. Cerclage is effective in patients with mid-trimester cervical dilatation and efficiency, acute cervical insufficiency. If you're going to use them, remember antibiotics, heparin, because antibiotic, heparin, and indomethacin, this is what was used in the only randomized clinical trial. I doubt that there are going to be many more randomized, or ever a randomized clinical trial of cerclage in cervical insufficiency.
Okay, great.
Okay. Then thank you to all of you for participating. Thank you for the participants who are following us and joining us for the Congress. We'll see you tomorrow.
Thank you very much. We'll see you tomorrow.
Thank you, enjoy very much.
Thank you very much.
Bye-bye.
See you tomorrow.
Tomorrow.
Okay.
Daniela?
Yes.
Bye,
Do you have
Daniela.
2 minutes? You have 2 minutes?
Yes, of course.
I would like to